Namaskar. Very good morning to all of you. I'm Saurav Shandilya from My Rehab Academy. We are going to see today, as the topic says, X-ray interpretation. Hope I'm audible to everyone. You could send in chat. I'm seeing everyone's chat today, so I'll be able to see. Just say yes, either by thumbs up or you can type in the message. Yeah, thank you. Thank you, Keshav. Thank you, Piksha. So I'm audible. Well, few of you would have joined this class earlier, and as you know, every time when I take this class or any one of my class, that always remains different from the last class. So today we are going to see X-ray spotter series, but before that we will see why it is important and how much it is important for the physical therapist. Third thing, we are obviously, this is a full course, X-ray full course. Last year I took, and many of them, they joined. Still their exams are pending. And thing is, like, it was complete X-ray for a physiotherapist for different conditions, right from head to toe. And after that, you know, after a certain interval, based on your demand, I actually take this class only for benefit of you guys, and every time it remains different. So today we are going to see X-ray, but before that I would like to clarify something. Thing is, few of you were asking when is the class for dry needling is there. Yes, dry needling has been announced. All of you can join. In fact, few of you only can join because we are not taking much people. So whoever applies, and after that we'll see depending upon a lot of stuffs and location. So it's in Bombay from August 2nd to 6th, 5 days, complete both module by Sir Craig Smith, one of the renowned person for dry needling stuff across the globe. So we are inviting him for taking your class. So those who are looking to enroll for the class, kindly send to your respective group and you will be helped to that. And in fact, you will be getting additional 5% discount. Apart from the discount you are already entitled for till now. Apart from that, we are having a sports econ, that is a e-conference based on sports. Resource person from Australia, New Zealand, South Africa, England, many other countries. Yeah, thank you, CEO sir. Thank you. I wanted this. Yeah, so this is the Club Physio and My Rehab Academy. Proudly we are presenting International Sports Rehab Econ. And this is wonderful event. You are going to learn from various person, and it's at the cost of a movie ticket. So it's something that 16th July on Sunday, you can make your Sunday vibrant by joining this, as you all are joining today to learn something new. So this econ will be way different, because 2 years before we actually organized and we had only 100 intakes, and I can tell you that still people are demanding, we want to learn the content. So it's the part of that is there on the YouTube, our channel. So I would request everyone to go through on our YouTube channel. There are a lot of things, and there are many things. Yes, it is online movie, and there are many things we are having on YouTube. You can learn it, and on our YouTube channel you can like it. And there is a premium subscription is being rolled from possibly from 15th July. So you all can take that also. That will be very, very cheap for our members, for our life members, and those members who are joining now on the yearly basis, that is free for them as well. So so this was the kind of a small introduction about the events we are having. And I don't want to say anything for My Rehab Academy, as My Rehab Academy needs no introduction when it comes to teaching and training for our fraternity. My focus is more on the students, because many more students keep asking me, messaging me personally, sir, when are you taking electro class, when are you taking ECG class? So there are many topics, even few of them they have told me for the physiology, anatomy, all those things. So everywhere I'm not expert, but whichever is my subject of choice, whichever is of subject of teaching, I definitely will look into that. And in coming month, few of you were asking for the electrotherapy as well as the cardiopulmonary physiotherapy. Yes, cardiopulmonary physiotherapy, we will have 8 hours of online, like online as well as the demonstration, everything. That event also will be there, and complete e-class also will be coming. All depends upon the timing, and the task assigned by My Rehab Academy to me, and depends on my timing as well. So let us start without giving much more time. I was thinking 10 minutes I'll take, and I've taken 8 minutes. This is still better. So I'll share my screen. I think I'm able to. Yeah. Yes. All of you are able to see the screen? Okay. Yeah. I'll try to make the screen bigger somehow. Just give me 50 seconds. I mean, 13 seconds. Sorry, 30 seconds. And yes, it is being live streamed even on the YouTube channel. Yes, you all, whoever wants to join there also can join. That's not a problem. 30 seconds. I mean, 13 seconds. Sorry, 30 seconds. Yeah, it is. So just 1 minute. I hope you all can see the bigger screen now. Yes, I will check that. Yeah, working. Thank you. So it's X-ray interpretation for physical therapist. My dear friends, we are going to see in short, and I will clarify a lot of things. As I told you, like most of my classes are different from the classes like it used to be earlier. So this class, I have decided right from the initial phase that I will clarify in your ionizing part and a lot of radiation part. Why? Because it's not confuse you when you proceed further. So let us go for the next. Yeah. So we will have a spine spotters. We will have lung spotters if we get time. If we get, because spine spotters itself is a class for about 7 to 8 hours, because this should constitute the best for the physical therapist, and of course the lung, my own favorite, and all of us understand. So we'll see whether we can today we can finish spine and lung in shorter and better descriptive way. So before starting spine and lung, I have certain questions from you. Why do you think that seeing an X-ray film is important for a physiotherapist? Everything is there already in the impression paper, right? Already there in the result, result paper. So why do you think this is important? And what do you see actually? Any one of you or few of you, if you can answer in 30 seconds, what do you actually see? Then we will, exemplify that, the certain things. Yeah. Anyone? I'll wait for your message. Okay, respective fracture, more precise anatomic finding. Very nice. Any I think yeah, very nice. Anything else you feel like CP angle? Very good. Very good. Sometimes lab technician might miss important details. That's true. But it's all signed by a radiologist, so we cannot doubt. Okay. Any missing condition? Well, to verify written information. Very good. Very, very nice. I'm very happy with you guys. It looks like you all are very good in seeing X-ray, and you all are regularly seeing X-ray. See, this is our problem. We always see the impression and we don't see the film. So most of people, they don't see the film enough. See, if there is a fracture, and you always love to see the series of X-ray, whether it is joint or not. Very nice. This is what I wanted to hear. Nijin Senin, wonderful. Joint space comparison, wonderful. In fact, you can make it more specified, like a joint space study. Very nice, wonderful. So many things which is not there in the result, you could see that, like the bone is good or it looks like osteopenic bone. right? You can actually see the condition of more than the swelling, like which part. Suppose there is an elbow. I will not take elbow today anyway, but elbow, you have a lot of fat pads. So depending upon the fat pad, we see the X-ray. Anyway, any specific contraindications for exercise which radiologist doesn't mention? Wonderful, wonderful, wonderful. Obviously, they will actually give their clinical significance. So today we are going to see, like a historical facts. We will check for our like some of the historical facts, because I always believe the science, when we don't know the history, who has brought this is something not good. We should always respect whoever has done too much effort, in bringing the science to us. So, and then biophysics and general principles, then terminology is very important. Today I'll clarify. From last class, somebody asked me, sir, can you clarify all these things? I thought that but when I was taking lung, then I was getting like messages continuously. So I will clarify initially only. And after that, the importance of normal anatomy knowledge, that anyway, I believe that's very important. And 20 clinically important conditions, especially in the spine and lung. You can always ask your questions throughout the session. I'm on for that today. So today I have increased the screen, so I believe that it's working. So historical facts, I will not get into much detail. Okay, I will not get into this theory part. I will go to the short. This is the person, William Röntgen, who actually is given Nobel Prize for discovering X-ray, and actually in 1901 he did it accidentally, and this is the first X-ray of humankind what you are able to see on the screen. So that is of his wife, and you can see all this ring and everything. So yeah, so let us go for the next image. Yeah, so these are the few scientists, in fact every day the research is on, the science is on. You see, science, we never lose the game. Either we win or we keep trying. So W.C. Röntgen, okay, William Röntgen, what we were talking just now, he is credited with the discovery of X-ray. Okay, he got Nobel Prize in 1901. It was this great scientist, Godfrey Hounsfield. He is credited with the CT scan discovery. Hounsfield is so popular that we are crediting the unit, HU. Anyway, when I take CT, you will be knowing that. Many more messages I'm getting when I'm going to take CT or MRI. Well, CT and MRI are the part of the complete this one. But yeah, 1 hour CT class, I'll take one day. A lot of messages I'm getting. I'll see. Peter Mansfield, MRI. Okay, MRI is something is seen with the Peter Mansfield, who discovered it, and obviously I'll come on that later again. Felix Bloch, NMR, nuclear magnetic resonance. Okay, all part of nuclear medicine. So nuclear magnetic resonance. Then Charles Dotter, interventional radiology. This is the part of radiology. Anyway, we'll not get into detail. John Wilde, ultrasonography, and Robert Egan, mammography, X-ray of breast. Okay, mammography is X-ray of breast. So these are few names, few giant who actually has a big contribution in scientific world of radiology. And today, being a physiotherapist, we need to learn which is important for our profession. And so we all students of physiotherapy today, we are sitting here to discuss few of the clinically important conditions and how to see that. That's all. So we must salute to these guys. And this is something, this kind of image, I will not say this very image, but this kind of image is favorite of mine in complete science. If somebody asks me which is your favorite image, I always say the electromagnetic spectrum has been my favorite image, always, and always. Why? Because you believe it or not, the quantum health care is the new future. Okay, integrative medicine, right from your allopath, physiotherapy, Ayurveda, other science, natural science, it's an integrative medicine is the future of humankind. And quantum physics is something I consider is the holiest of science. There are a lot of reasons behind that. I will not get into that, but yes, this is something, the electromagnetic spectrum, which is our, you see, this is the only part we are having a visible range, right from the class 9 we are studying. Okay, and then more than that, we have ultraviolet, then infrared, and then in coming down, the frequency decreases, and going higher toward gamma range, the frequency increases, but wavelength decreases. Why? Because, okay, let us have certain physics here. There is a formula called V is equal to n lambda. I don't know how many of you know, but V is equal to n lambda is, okay, V is equal to velocity of particular wave, n is frequency, lambda is a wavelength. So wavelength and frequency, whenever you are multiplying, this will be constant. So that you can see wavelength is less, and you can see accordingly frequency is like that. So electromagnetic wave will have speed, and that speed will be the product of frequency and wavelength. You could see we have different, and then different wave has different. You see visual light only we can see Vibgyor, what you say, the 7 range, right? Apart from that, we have infrared, microwave, microwave oven. So every wave has use. So which we can't see, we feel the effect. So the thing is, not always seeing is believing. It is the perception is also the believing. Okay, so there are a lot of things in that. And then when you go, then TV, FM radio wave, and after that it comes shortwave radio, shortwave, AM radio. Earlier we used to have radio set, in that you find FM radio, AM radio, shortwave. Nowadays everything has come to mobile, so many of my new age generation may not be knowing AM radio. And then long wave radio. In my own home, we used to have this big radio. I mean, obviously nobody used, but this big radio, and it used to have antenna. So those days, slowly technology developed, transistor became more powerful, more receivable. So radio sizes decreased. And I was saying 10 years before, when they were using the pocket radio. Now everything has come into the mobile. The radio feature also, your walkie feature also, everything. Okay, let us come on the subject. Yes. Now we will clarify certain terminologies. Okay. Well, before I get into this terminology, I'll ask you one very simple question. When you take MRI, any one of you, I wanted to clarify this, like before I get into the spotter series. Yeah. When you take MRI, and for what you take MRI, I will check your message. Soft tissue injury, wonderful. To see soft tissue injury, I agree. But first investigation of choice is always X-ray in most of the cases. However, when we talk about the spine, we'll come on this phase later. Again, so see here, X-ray. If it is a black, what do you say? You have to say lucent. When it is like a white, when we say opaque. Okay, but in CT, things changes. CT, we don't use lucent. We see what? Hyperdense. Okay, depend upon the density we find out. And then we have a intensity, like a hyperintense. If it is a white, where? In MRI. So in MRI, when it is a black, we say hypointense. When it is a white, we say hyperintense. Come to the USG, what we say? Hypoechoic. If it is a black, hyperechoic. When it is a white. Okay, so this is the certain terminology which we actually use just to differentiate certain image. Okay, well, now yeah, we are done with this. Anyone has any question? I mean, you just check for lucent today and opaque today, because our subject of watch of today is X-ray. Lucent we say black, opaque we say white. Clear? So this terminology last time few of you were asking when I was taking lung. Okay, one more. Ionizing fear we will clarify today. Ionization, 100% is ionization. So electron is a particle or wave? Let me see in your chat. Because X-ray, it's very well like the cathode ray, when it hits the scintillation point, it creates X-ray and everything. But Electron is a particle or wave? My question to you. Send me message, no problem. Anyone? Particle, dual nature. Wonderful, Abhilasa. It's a dual nature. Very nice. It's a dual nature. It's not only particle. Okay. J.J. Thomson said particle got Nobel Prize. His son, after 30 years, he also got Nobel Prize, I believe, saying that it is a wave. Yeah. And Max Planck, recent of all these. No, wait, everyone now. So Max Planck, the father of quantum physics, he said it's a wavicle. It's a dual nature. Okay. It's a dual nature. So particle as well as the wave. And he got the Nobel Prize. And I believe personally, he's wonderful in this way. Now, if you consider these things with our literature, everything, it actually works. So electron is a wave as well as the particle, as you said, dual nature. Yes, true. So everything in the world is like that. And now let us talk about ionization. Causes what? Why do we see ionization? Just 1 minute. Yeah. So ionization causes what? DNA breaks, free radicals, as the name is saying. Okay. So rays like your X-ray, gamma rays used in the radiotherapy, PET scan, all of you have heard PET scan, scintillography, all these are the part of like diagnostic part, obviously. And then cosmic rays, background. Particles like protons, electrons, neutrons, helium nucleus, alpha particles, all these are only for therapy purpose in nuclear medicine. It doesn't have any diagnostic purpose. Non-ionizing like your MRI, USG, thermography. So MRI can be done without fear of ionization. Clear? Every one of you clear? Yes. So don't keep any doubt in your mind. MRI, USG, thermography. Thermography nowadays, I don't think it's being used. Earlier, it was used to in regard of breast cancer, but thermography is no more in use now. Ionizing, radiography, always two-dimensional. CT, three-dimensional. Fluoroscopy, contrast study. Okay. Yeah. So HSG, all those things. Now ERCP, and apart from that, ionizing gamma rays used in PET scan, SPECT, scintillography, 2D. What is scintillography 2D? Any one of you have any idea? In your hospital you are seeing scintillography 2D? Okay, this is your question for the session. You can answer me last, no problem. Okay, so this is nothing. It is a X-ray only, but here we don't use the X-rays. We are using the gamma rays. Okay, very nice. Now, certain biophysical principles, as I showed you the earlier figure, like X-rays are wavelengths of electromagnetic radiation, and short wavelengths of electromagnetic radiation that penetrate matter are the beam of ionizing radiation emitted from the X-ray tube during the exposure. Okay, a traditional radiograph is created when the X-ray penetrates the body structure, okay, and produce the image on the photographic film, usually contained within the cassette, replaced by nowadays in digital images in modern era. X-ray is a term frequently used to refer to the image film produced. Actual term is a radiograph. Okay, X-ray is what? X-ray is, you know, X-ray nikal ke la. Acha, I'm getting message here. I'm really sorry to you guys. I got message to speak in Hindi as well. Okay, sorry, I forgot completely. It was message before starting the class also. I'm really sorry. तो आप कहते हैं ना X-ray ले आइए. So get the X-ray, but actual term is radiograph. X-ray is what? X-ray तो wave है ना. It's a wave. So we have a radiograph paper where we see the X-ray. Well, so radiograph is what? It's a 2D image. 2D image. If you're taking my chest X-ray, you'll be taking on a paper, right? You'll be taking on a paper, and that paper will be two-dimensional. So depending upon which organ is bigger, which is showing opaque, lucent. Depending upon that anatomy, we decide our clinical conditions or clinical findings. Well, so acute localization of an abnormality frequently requires two radiographs. Always remember, two radiographs at different angle, especially the right angles to one another. However, in some of the cases, it is a special angle also. So you always like you have always see there is a AP view, there is a lateral view, है ना? होता है ना lateral view. AP and lateral is very common. However, in chest case, you have a AP view, PA view, है ना? यहाँ पे PA भी होता है. Why the PA is important will come later. Okay. Apart from that, have you heard of skyline view? Any one of you? Skyline view? I'll be very happy to hear because I know today very energetic people are. Yes. Can you tell Sahil when we use skyline view X-ray where we see patella? Wonderful. Come, let be more specific. Patella में होता है और patella में क्या देखते हैं? Particular thing. Okay, patella के लिए ठीक है. X-ray everything. Okay, right. There is a condition called CMP, chondromalacia of patellae, PFA. Okay, very good. So skyline view. Now there is something called oblique view. Can you give example where we see oblique view? Wait. Sorry. Yeah. Can you give example where we see oblique view? Any one of you? Just one example. Oblique view में कहाँ देखते हैं हम oblique view? Any one of? I'll check. Scaphoid fracture. Okay. Anything else? Ankle. Wonderful. Wrist. Wonderful. Thank you. Okay. Now, very important thing. Let us understand where we see the open mouth view. Open mouth view. क्या चीज को देखने के लिए करते हैं? Any one of you? Open mouth view. Where do we use open mouth view? Okay, we'll discuss that anyway today. But there is something called dance, Atlas, Axis. याद आया कुछ? There we actually use the open mouth view to find out the position of odontoid process. Wonderful. Sphenoid, odontoid process, cervical. Wonderful. Odontoid process. Nice. So you all know about it. So certain views are very important apart from our AP and lateral views. So now, yeah. So as I told you earlier, now will be more detail. So same for conventional X-ray film or digital image, the interpretation will be there. White color indicates the underexposure, black indicates the overexposure. Radio opaque. क्यों होता है opaque? Because it absorbs all the X-rays. Again, quantum physics, everything, whichever is appearing white. Why? Because it is absorbing all 7 visible color. However, X-ray is a monochromatic stuff. So here we are not talking about color, but it absorbs everything. So it appears white on film. Radiolucent is what? It appears black. Sorry, we'll not talk about color. I think this is a misquoting. Just leave that. Yeah. So radiolucent, soft tissues, air absorbs partially, so appear gray on the film. Here the story come in picture. Soft tissues, air absorb partially. Suppose it absorbs completely, full black, less partially, it will appear gray, more gray, less gray. So, completely depending upon the gray, we actually have idea to decide the clinical findings. Now, next picture, it is showing the, just 1 minute, I will reduce that. Yeah. So this particular image you could see here, you can see air completely black. Okay, this is the basic radiographic densities. Always keep in the mind. Fat, dark gray, water, light gray. Okay, bone, very white. Okay, white, in fact, calcium, white. Metal is very white, bright white. What you say is the metal. bright white. Okay, so this is the scale. You can always remember white, toward whiter, the solid tissues like metal, and then obviously bone, our bone, and then muscle. Then if you come down in this category, blood, liver, lung, fat, and then air, completely black. So getting black in your chest view is a normal most of the time. However, this we have to see. Yeah, so checking your chat. Okay. So this is the basic radiographic densities. Always remember that. So X-rays are needed. Obviously, it's the first investigation of choice. If we talk about investigation of choice, X-ray is always the first. Why? Because it is easily available, economical, and very fast. You can actually process the report also. So chest pain, breathlessness, cough-related symptoms, trauma, obviously the most important, clinical examinations like tachypnea, panting, abnormal chest shape, anything, fever. So preoperative essential, abdominal distension. So it constitutes an investigation of choice for most of the conditions in like initially. And then obviously medical legal cases, or even in the insurance, everything, the first thing for the X-ray of chest is one of the kind of checklist for them. So most of the cases like that. So next, interpretation, the most important interpretation of X-ray. Basic, very basic interpretation we'll see first, then we'll get into the spine. And before you interpret, you need to ensure something. What? You have to check patient name, which is always there in the side marker, left or right on films, or side, left, right, everything. You have to check it where it is written, whether it's correct, wrong, anything. Okay, means side is very important. Now again, clinical details like age, gender, history, everything, you need to check it. This will be there, and you need to see these things first. These all are the checklist. Okay, so always you should check in the X-ray box. Don't check into the normal, many a times the X-ray box is not like people will do what I've seen this kind of problem, especially in the home care cases for physiotherapists. See, this is the ground reality. I could tell you, being a physiotherapist, what happened here. Here, what happened, I have seen people actually go for home care, and obviously they cannot carry the X-ray box. So what happened, if they see the image, they'll be seeing in the tube light. I have also done for some time in the tube light or in the bulb. So what is the problem? You are using a bright light, okay, and it will give trouble in your reading. Okay, you may not be able to read properly. So it's always good to get into the like a proper X-ray box. You get your reports to your clinic and you read it properly, and avoid reading in very like small, very bright light and a small place. Like it should not be like that. It should be equally distributed. That is something very important. Okay, so other thing is like interpretation. We will check now one by one. Okay, so this terminology, so पहले का जो terminology था, that was mostly related to how do we see on the X-ray paper, lucent or opaque. Now these all are pathological and anatomical things. Sclerotic, very well, increased bone density, lytic, bone destruction, everything. That kind of terminology I'm talking about, because these terminologies are more frequently used when they process the X-ray reports. So all you know about it. So AP always see as a anterior-posterior. PA is always a posterior-anterior. Lateral is from side. Oblique between lateral and anterior-posterior or posterior-anterior. Decubitus, it's a lying horizontal, being on your elbow. Supine, lying on the back. Prone, as you know, face down. Erect, standing. Erect, you cannot take always in erect position, especially the PA view is taken in erect position, but for the patient lying on a stretcher, you can't expect that. I'll tell you what is that view called. I have not discussed earlier that view. We'll talk in another 5 minutes. Axial, along the axis of an anatomic structure, cephalic towards the head, caudal is towards the feet. All of you know about this. And so importance of anatomy knowledge, I'll say only one thing. Whenever you get time, nowadays you have a beautiful atlas, everything on the Android mobile. You have app also for that. So if it is possible, you purchase certain you purchase certain membership and be with the anatomy. See what happened now. Also sometimes I read anatomy, the basics, like the brain anatomy, like something I keep reading. Why? Because if I don't read, I believe that I shall lose. Okay, so reading is very, very important. So read every day, just read. Don't need to remember, because you already have remembered right from the first year of your physical medicine. So what happened, when you read it, it remains with you. Otherwise, many things which goes out of brain. So fractures classification, I have just kept in this slide. However, you all know about this fractures classification. There are many methods of doing the classification. So basically, if we talk about this, you can see this is the, I'll come directly on this. So this is the transverse fracture. This is the linear fracture in the bone. This is the oblique non-displaced fracture. Here it has gone apart, the parts. So it is a oblique displaced. Then you have a spiral fracture. It goes like this. Okay. Then you have a gray stick fracture, common among kids. Then you have a comminuted fracture where you have a different bone pieces and more than 2 sides. So these all are the types of fracture. Now, before getting into that, okay, it's a dislocation and subluxation also. Now, you know, this dislocation, we have to check in the X-ray. Many a times you don't find the fracture. So what is that? That is a luxation. So that is what you say, dislocation, basically. So articular surface are fully displaced from other and opposition is lost between them. But subluxation exists when partly displaced, not completely from each other. Okay, this is how the subluxation and dislocation you find out in X-ray as well. So here I have given certain images. You could see here, you can see you can actually see in this image also. You can actually find out the schematic diagram here. So these all are very basic. You all know fracture in children, you know, type of fracture like complete grain streak, buccal fracture, pipe fracture, bowing injury, infants, toddlers fracture, epiphyseal, metaphyseal fracture, avulsion injuries. However, these were not needed, but I kept in my slide only to get you remember. And I also should not forget you before getting into the spine part of that, spine part of fracture. So radiographic diagnostic of fractures. After doing this, we will get into our core for the day, spotters for the day. So radiographic diagnosis, I would request every one of you to switch on your video, because as per the rule of My Rehab Academy, if video is not switched on for more than 80% of the time, it might lead to a problem in the certificate, because the system is like that. It's not something we are doing. So I would request every one of you, wherever you are in the clinic or you are studying at home, please switch on your video. Well, so how do you diagnose the fracture? Basically, it depends upon the features in that. So first of all, take a schematic diagram. This is the bone, complete bone. It got fractured. 2 pieces different. Okay. So what you say? Loss of continuity of cortex and a dark line through the adjacent bone. Well, so you see the continuity being lost. See, in X-ray of fracture, say for example, femur fracture, what you see? 2 white, like the complete one single bone should have been there, the femur. Now you are able to see it is different. There are 2. So continuity is lost. That is the number one what we see. And then fracture will appear as a sclerotic line, the kind of dense line, right? It's not necessary that fracture ends will be separated. It could be overlapping also, that we need to check. Okay, now, so what happened in some of the fracture, like a skull fracture where it is depressed, it's difficult. Why? Because it is an overlapping, like a what we say, it is looking like a ends are overlapping, so it's kind of dense. So that we need to check out, very, very important. Now you have two views, as we spoke earlier, AP lateral or other views, special views also. So in the two views, it is taken only to see what it has to be taken to see the kind of deformity at certain place whichever has come at fracture site. Okay, so it is always important to show this X-ray paper, I mean the radiograph, the joint above and joint below. Okay, any suspected long bone fracture, just to rule out whether the injury is still more or less. So nearest joint always they include in the film. Okay, some conditions could be there where fracture may not be visible on the radiograph at the time of presentation. I have seen this many cases. Why? Because undisplaced fracture, lot of cancellous bone, like scaphoid fracture in wrist. Okay, stress fractures. So what happened in this case? So a person, suppose, fell from bike, went to the hospital, they found a fracture here. Okay, they found a fracture here at distal end, and they found nothing, but they kept immobilized. Patient came back to home. After 5 days also, even after taking painkiller, pain is not reducing to significant amount. So he had doubt, went again to hospital. Doctors had doubt, again got an X-ray. Doctors was knowing, obviously they'll be knowing, it could be another fracture. That time you can see the fracture is there in the small fracture is even there in the metacarpals. So it's not always that the day one you get the fractures in some time. It could be even in the next day. So fracture healing also can be seen through the radiograph, and this constitute the very important factor, very important matters for the for our physiotherapist. Why? Because we have to take a series of serial X-ray paper, serial radiographs. Okay, serial radiographs, what we see whether fracture is healing or not. Well, we are seeing the healing or not. All of you know about the phases of fracture healing. I will not get into second year pathology, chapter number 2. 2? 2. Yeah. So chapter number 2. So inflammatory, reparative, and remodeling phase. So remodeling phase goes at last, and it actually, the callus, the compact bone is getting more and more. So that's where we see whether the fracture is healing or not, seeing the first, then later, and then later on. So this is how we need to check out the fracture. And then obviously the complications of fracture also in the X-ray it is seen. Okay, we can see whether it is joined properly or not. Okay, the proper anatomy is there or not. We can actually see still there is a swelling. I mean, in case of, say, for example, osteomyelitis, it's not a fracture. Okay, in that case we can find out whether there is any, still it has been properly healed or not, condition is healing or not after taking NSAIDs and antibiotics, everything. So even in the bone infection we are able to check that. Then we are able to see the avian, avascular necrosis, one of the condition even the young suffer sometime. Recently I saw a case, and it's really difficult. And then we are seeing the extrinsic complications like adjacent, injury to any adjacent vessels, nerves, tendons. Obviously, those soft tissue will not be visible, good, but in terms of swelling and everything, we can check it. And then injury to viscera, we can find out fat embolism. Sometimes the bone marrow fat can release to the lungs. So those all things. And then reflex sympathetic dystrophy. So it's a big topic. It's a vast Sudex atrophy, what you say. But for physios, these all things are very, very important. So now we will talk about some of the conditions. So cervical spine. Okay, we'll get into that. So I'll check the time. The time is 10:48. Okay. I'm checking some of the messages. Is there any question? Wait one sec, give me time. Okay. There is no question. Thank you. So when it comes to cervical spine, we will talk about the spine, like a cervical spine. So what is the investigation of choice in, so what is the investigation of choice in cervical spine cases? Obviously X-ray will take, but apart from that, there is something called NCCT, non-contrast CT, right? Okay, I understand. NCCT. I'll come on that, what you asked. Okay. So NCCT spine is the investigation of choice in most of the time, but we need to start with the X-ray. So there is something called nexus. Okay. The full, if you full form of this is a National Emergency X-ray Utilization Study. So, it says certain points when we need to take X-ray. However, for a physio, it is just too important to know about it. So when to take. Okay. So, there is no tenderness in cervical spine, basically, midline, basically, there is no tenderness, no focal neurological deficit. Apart from that, normal level of orientation, person is alert. Okay. And obviously no intoxication. So these all are points of nexus. No painful injuries, distracting injuries. And then obviously there is something called 45-degree of head turn. So apart from these points, if you add up the 45-degree head turn, so you have to just make the patient lie down, and all these things not important for you, but I'm just telling you for information purpose. So get the head turned down 45-degree side. So is there no problem, the test is negative, then X-ray is okay. X-ray we have to see. However, we need to find out X-ray, why it is important for, what all things are important in cervical spine. So we'll come back on this page again later. First, learn something important. So cervical spine, क्या करते हैं cervical spine के लिए, which all views are important? हम लोगों ने डिस्कस किया था ना, AP, there is a special view called open mouth view. Yeah. And one more view. I told you that time, I did not tell you. छुपा लिया था मैंने, बाद में पूछूंगा क्वेश्चन, but I'm not asking you. Cross table view. हाँ ठीक है, सही, you're okay. Cross table view. ये cross table view, why it is important? I'm sure that majority of you have not heard of cross table view. See what happened here, the patient is lying down. You cannot say patient to, you have to bring the machine on top, that X-ray will move and you'll get the film, everything is okay. But you cannot say patient, abhi khare ho jao, I will take your X-ray. It's not possible from the lateral view, right? So what you have to bring? You have to bring a screen, all those things the technician does. They bring their screen, and from side they take one view. Okay, so that is called the cross table view. Okay, so that is also one of the view important. Sometimes you should not get confused. So especially those who are preparing for your masters, and also they are being asked sometimes in Viva and all those things. So it will work for you. So especially the what Sahid told just now, odontoid open mouth view, mostly it shows odontoid and odontoid process and occiput, obviously, and then C2. So all these things, and the lateral view is useful mainly for when you make the patient horizontal and take the lateral view. It's important to take our findings to the better conclusion. Now, let us discuss about what all things are important. But before that, I don't know whether I have taken that photograph, but that photograph was too good. How many of you are aware? Yes, this photograph. How many of you are aware of this photograph? Any one of you? This we say as Danish lines. अब डेनिस लाइंस में क्या क्या होता है आप देखिए. दिस इज अ एंटीरियर वर्टिब्रल लाइन. वर्टिब्रा के आगे से जो लाइन है, ओके, दिस कर्व लाइन, ये जो है ना व्हाइट कलर वाला, दिस इज एंटीरियर वर्टिब्रल लाइन. लेट अस से सी दिस लाइंस, प्लीज अंडरस्टैंड. आपको चाहिए तो आप स्क्रीनशॉट ले लीजिए. अगर आप स्क्रीनशॉट नहीं लेना चाहते हैं, व्हाट यू कैन डू, yeah, it is coming on YouTube also. You can actually later you can just see and revise. See the video for 2 times, no problem. But just take X-ray like to the level what you want to learn. Okay, so ये anterior vertebral line है. And then you have a posterior vertebral line, you know, before the body. And then you have a spinolaminar line. Then at last you have the spinous process वाला line है, interspinous line. Okay, ये सारे lines हैं. But ये lines का करना क्या है? These lines are going to tell you what is the condition of bones or what is the condition after injury. The line is so important. Okay, it's very simple to remember. Anterior line, body के anterior. अभी आपका, say for example, don't laugh at me, I'll make a schematic diagram. Say for example, this is the vertebra. ठीक है ना, ये वर्टिब्रा है, ये आपका आगे का लाइन है, द बॉडी, दिस प्रोसेस. ओके, सो स्पाइनस प्रोसेस एट लास्ट. सो व्हाट हैपन हियर, आगे का लाइन एंटीरियर वर्टिब्रल लाइन, बॉडी के पीछे वाला पार्ट पोस्टीरियर वर्टिब्रल लाइन, लेमिना वाला पार्ट स्पाइनोलेमिनर लाइन, और सबसे पीछे वाला पार्ट इंटरस्पीशियस लाइन, इंटरस्पाइनस लाइन. ये 3 लाइन 4 लाइन तो दे दिया डेनिस ने, बट व्हाट वी नीड टू चेक आउट इन दिस, as per this line, we have to see the alignment disturbed, whichever has been disturbed. Okay, so routine radiograph, when you check, this is the view as we already discussed, AP view and cross table and odontoid view, just to see C1, C2 articulation. So this is the thing we need to check it. Okay, so whenever you take radiograph of cervical spine, never ever forget to check these 5 points. क्या क्या? Vertebral alignment, spinous process alignment, vertebral body height, disc space height, prevertebral soft tissues. आप डिस्क को तो नहीं देख पाएंगे, बट डिस्क स्पेस की हाइट से you can say too many things. Okay, and then the need of MRI comes seeing that. So vertebral alignment. Okay, I'll go through this theory, and then again I'll further add up my own theory. I'll further add up some more things which will clarify your many doubts. So vertebral alignments, 3 smooth unbroken lines, arcs, I'll find out. So arcs should be present in normal spine. Okay, so just now we see these 3 things. Okay, so disruption of any of these lines should suggest the significant trauma. कहने का मतलब है, suppose this is the vertebra. Okay, these lines are coming like this, imaginary lines. Okay, अभी आपका एक एक्सरे आया और इस एक्सरे में you are able to see like this. What you will see? The lines are disturbed. That means there is just something wrong with this. Okay, that is the beauty of these lines. Number 1. Number 2, alignment of spinous process. Very, very important. Okay, so spinous processes should be in a straight line in AP view and at equidistant on the lateral view. If it is not equidistant, means at certain distance, there is something wrong. How it is wrong, we will see later. Okay, vertebral body and disc height space. Vertebral bodies, should have a relatively uniform square rectangular shape, that anyway you all know. Apart from that, if there is a loss of height in vertebral body, that says what? That could be the compression fracture. Okay, widening of disc space indicates what? It could be the disruption of disc due to any of the reason. Narrowing of disc says what? Chronic conditions, common in old ages, right? कहते हैं ना, एक्सरे देख के कहते हैं ना कि आपका डिस्क का स्पेस कम हो गया है, ऐसा बोलते हैं ना. So that disc space get reduced only, like you can see on the X-ray and can say that. So prevertebral soft tissue, how? Here there is a calculation. Okay, so prevertebral soft tissue, if you see in the lateral view, it should not be more than 30% of, the width of from C1 to C4, and no more than 100% of width from C5 to C7. Okay, if it is more than that, it shows some abnormality in the soft tissue, prevertebral soft tissue. So 50% of the patient with bony injury, you find that as per incidence. And it's important to remember what? It's important to remember always the absence of soft tissue swelling does not mean that the injury is not significant. That's the reason we go for MRI and other things. Here you can see in this image, again, we'll come on that later, but I will actually get your anatomy also revised when it comes to C1, C2. I'll ask you the questions, certain questions you all have to answer. But before that, just let us have a basic discussion on that. See here, C2 and the C3, आप line को मिलाइए. क्या लगता है आपको? Is this line is continuous? No, it is not. यहाँ पे देखिए, spinal laminar disturbed. ये वाला line देखिए, posterovertebral line disturbed. अब आप समझ गए? आ जाइए इस पे. Where we were? Yeah, here. Spinous process को मिला के देखिए, disturbed. So there is an injury, right? So here, come on this page. See, यहां तो लगता है बंदे का पूरा वेज ही आ गया है बाहर. So this kind of, see here, कहां से कहां लाइन जा रहा है, right? Spinolaminar का भी वही हाल. So lines are disturbed. That means there's a first thing you have to check. So कल से या आज से जब भी आप अपने क्लिनिक में जाएंगे या एक्सरे देखेंगे, practice those things. Okay, you don't need anyone's help. You need just to see. क्या देखना है? Lines देखना है. Whether line is continuous or not. If line is not continuous, there is definitely some problem. Okay, next. Coming to the fracture of C1. Before that, okay, C1. C1 को हम कहते हैं atlas, right? So it may be fractured by vertical force through the skull. I'll come on that, like how lateral masses of C1. तो उसमें क्या होता है? Jefferson fracture, everything you know. This is the open mouth view. You can see from here this dense odontoid process. What you say here, you see. अभी इसमें जो fracture होगा, you can see in the open mouth view only. Okay, okay, fracture of C1 and C2. यहाँ पे हमें जो the most important part देखना है, so to get in, like a detail of this even more clearly, what we have to see, we have to find out the mechanism of injury, MOI, mechanism of injury. Why it is so important in case of cervical, in case of spine, basically. See, whatever you read till now in cervical, that is something I gave you as a, like in my PowerPoint, I have kept something, I read it and I tried to make you understand technically how the lines are disturbed. Now let us get into even more deep detail so that, there is a good saying by old doctors, as much as you collect history, you can have your assessment so better and you'll be so experienced that later you can collect it even faster to get your findings faster. So mechanism of injury देखिए. So what all mechanism of injury it could be? It could be hyperflexion, है ना? Hyperflexion, suppose इस तरफ आता है तो, or hyperextension, or anything else, you think it can? Axial loading, very very important when we talk about even the like lumbar vertebra, हम लोग इस पे भी बात करने वाले हैं. Axial loading. ये axial loading कैसे होता है? The vertebra, suppose this is the vertebra, schematic diagram. Okay, this is the spinous process. Okay, so अभी कोई है जो घर से चोरी करके भाग रहा है. Okay, and that man jumps from the first floor or second floor directly on the ground. What do you see? The force will go like this. Okay, and it will create the problem for the lumbar, obviously lumbar. Okay, तो lumbar की तो अभी हम कहानी ही नहीं कर रहे. Now we are talking about cervical vertebra. So ऐसे केस में axial loading कैसे हो सकता है? A diver, any diver who is going to swim, it can have the diver injury, right? सीधा cervical पे लगेगा. Axial loading, right? So these loadings, like this mechanism of injury is very very important when we talk about anything in X-ray. Some mechanism of injury, some anatomy that makes you pakka for understanding this class. Okay, now apart from that, when we talk about okay, who all will tell me about the ligament of cervical area? Let us discuss this also, it's important. Cervical area के ligaments कौन कौन से हैं? And who all will tell this? I will check your message. LR ligament, well, I am not actually asking that, Lakshmi. I am asking what? I am asking right from the down. कौन कौन से ligament होते हैं? We have, suppose, I'll make one schematic diagram. Okay, यहीं पे use कर लेते हैं हम लोग. कैसे कैसे होता है पहले बताइए आप. Anterior to all the vertebra, what you say that? ALL. Anybody say? Anterior longitudinal ligament. I will check your message again. Yeah. So yeah, very nice. So then you have a PLL, you know, posterior to the body. What you have? Yeah. Posterior to the body. What you have? PLL. Then facet joints को connecting वाला क्या है? Ligamentum flavum, है ना? Facet joints को connect करता हुआ, है ना? And then उसके अलावा और क्या क्या है? सारे स्पाइन के बीच में जो ligament है, you know, it connects every spine. What you say that? Anyone? Interspinous ligament, है ना? And then spinous processes को भी connect करने वाला ligament है. What we say that? Supraspinous ligament. You know, all these are ligaments. All these are ligaments which makes us more stable, right? So अभी मैंने ये ligament का बात क्यों किया अभी आपको पता चलेगा. So when you go on top, I will not complicate you with that. There is a clivus bone and behind that there is a occiput and then on top this यहाँ पे medulla भी होता है ना C2 के लेवल पे, राइट? तो क्या है कि ये सारे लिगामेंट जब ऊपर जाते हैं then the name changes. So anterior longitudinal ligament कौन बोलेगा? क्या हो जाता है नेम? Anybody? Lot of messages. I'll find out. Yes. Anybody? Now I am waiting for your message. Ligament की story तो आपने कह दी. Interspinous, ligamentum flavor, everything. Now tell me, what is the name of ALL which it travels up? I'll be very happy to say. Anyone? I think somebody has. Atlantoaxial. Wait, I'll tell you. So it is a anterior atlantoaxial, but no more ligament. This is a membrane. ठीक है? Posterior longitudinal ligament क्या बनता है? Now I have to see the real question. Yeah, हाँ ठीक है, I understand, but I'm asking you one by one. Please answer me, please. One by one. Yes. I understand. So posterior longitudinal ligament. Anyone can say what is the name get changed into? Simple anatomy. I will not complicate you with the spine enough. Anyone? Check the message somebody has sent. Tectorial. Wonderful. Aman, wonderful. One more person has told tectorial. Somebody iPhone, so I cannot tell your name. So yeah, tectorial member, but wonderful. People think ALL से anterior atlantoaxial हो गया, PLL से posterior चिपका देंगे. It doesn't work that way. See, this is very systematically planned. Okay, so it is tectorial ligament. Very wonderful, wonderful. So happy for you, Aman and iPhone. Tectorial membrane. Well, and there are three ligament. Okay, फिर इसका भी बात कर ही लेते हैं. So ligamentum flavum. What it becomes? Ligamentum flavum. तो हम लोग आएंगे proper उस पे. Ligamentum flavum. Somebody sent me. Okay, my name is Mega. Sorry, Mega, I could not see your name then. So I saw iPhone. So well. So ligamentum flavum क्या बनता है? Anybody? Oh, super, Sahil. This is the posterior atlantoaxial. Wonderful. Wonderful. It is again the membrane. Well, anyone else? Wonderful. Okay. Ligamentum flavum की बात हो गई. All these are a C2 level. Huh? This is not at the earlier level. But ये जो हमारा है ना spinous वाला ligament, supraspinous ligament, this changed the name somewhere, you know, at C7, yeah, C7 level पे ही इसका नाम change हो गया. What is the name of the supraspinous ligament? What it changes the name? C7 के ऊपर जाते ही the name becomes the ligamentum nuchae. है ना? Nuchae. I think E is the last. Yeah. Ligamentum nuchae. है ना? Kamal. So these things we need to check in the, we need to keep in the mind what the ligament becomes. Okay, because all these are very important. Now we will come into a little deeper part. See, dens को तो hold करना है ना. If you see from the top, the dens को तो hold करना है. So which will hold? So that time what I think Sahil was answering or someone, I am not able to remember. They were asking the LR ligament. Yes, on top they have a LR ligament. Okay. So, and there is a cruciate ligament also, you all know, है ना? Cruciate ligament. And obviously the tectorial membrane तो होता ही है. तो apart from that, wait, I'll put it again. So all those things got discarded, no problem. You all know this LR ligament, what I was talking about, again, the cruciate ligament, and then you have a tectorial membrane. So it's very easy to remember what A, C, T, है ना? Act. ये वाला mnemonic आपने याद रखा तो you will be able to know the ligaments over here. अभी इसको hold तो करना है. Dens को atlantoaxial joint को hold तो करना है. So very, very importantly, which is the strongest ligament here? I'll just see, somebody sent me message. Which is the strongest ligament here? Anyone? No, not PLL. I'm not talking about that. I'm talking about at this level, C2 level पे सबसे strongest ligament क्या? PLL का तो नाम ही बदल गया, इसलिए आप उसको भूल जाइए साहिल. ठीक है? LR, no. थोड़ा सा और दिमाग लगाइए. LR से भी ज्यादा इंपॉर्टेंट है कुछ? कम. अब तो दो ही बच गया. Cruciate, because it is like this. Yes, Alfia. Cruciate, because it is like this. Okay, so it holds very well. Why the holding is very important? Because it protects the CVJ. You all know. CV joint का रहना स्थिर बहुत जरूरी है. And then medulla is also nearby. So LR ligament basically क्या करता है? अगर आप सही से देखो तो ऑक्सीपिट से अटैच है. Okay, so इसको होल्ड करने के लिए you have a something very important, like cruciate ligament is the most important to hold. Most important. ठीक है? No CVJ, no life. So it's very, very important. अभी हम फिर से डेनिस लाइन पे या डेनिस की थ्योरी पे नहीं जाएंगे तुरंत में, but we will talk something about the C1 and C2 vertebrae and everything. So अभी C spine पे let us be more focused. What we were seeing in those images, we will see in the image again, but we will come between the we will talk on the board first, then we will go on that. I am taking those what you say PowerPoint presentation for you mainly because it has been customary to show PowerPoint presentation, and without that it seems that you're not teaching, something like that. But I always believe I am the man of chalk and talk. So believe it me or not, I always love to go with either digitally tablet or in the class, the chalk and talk. So those my students in college also know that I always go on that. More than the PowerPoint presentation, I believe on that. However, the PowerPoint presentation I keep for you guys to see and then recollect the information. And for me as well, I should not go haywire from the studies, something else. I should not be stressing you more, which is the subject of study. We need to stick to that. That's all. So now see spine. अभी आप एटलस और स्पाइन को देखिए, दोनों के बीच के डिस्टेंस को देखिए. यू नो वेरी वेल, बच्चों में दिस इज लूज 5 mm, 3 mm. ओके, अगर मैं इसका एक स्कीमेटिक डायग्राम बनाऊं, लाइक सपोज दिस इज द स्कीमेटिक डायग्राम, और यहां पे डेंस का पोजीशन है. सो विच डिस्टेंस यू नीड टू चेक? You need to check this distance, यहां से यहां तक. अगर ये 3 mm है in adult, this is good. अगर ये 5 mm तक है in child, this is good. It is not displaced. समझ में आया आपको? It is not displaced. I'm coming on the picture later. First you see this. So atlantoaxial dislocation को देखने का सबसे अच्छा तरीका यही है. You need to check the distance. Now let us come on that. What I was talking. ये देखिए आप, you all could see this यहां पे. Just 1 minute. I think I missed that image. Anyway, just see this. Yeah, I think I missed that image. Anyway, just see this fracture. Anyway, I'm coming on that later again. Okay, so आपका अगर यहां पे इन दिस इमेज, आई एम टॉकिंग अबाउट दिस इमेज, जस्ट सी दिस. अगर आपका 1 2, मैं नंबरिंग ही कर देता हूं आपके लिए आसान है, 1 2 3 4, सबके सब टूट गए. एवरीथिंग इज ब्रोकन. ओके, ऑल आर बर्स्ट. व्हाट यू विल से? जेफरसन फ्रैक्चर. बट इसमें 4 part फ्रैक्चर मींस जेफरसन फ्रैक्चर. ओके, it's a burst fracture is playing the lateral masses of C1, of course. तो उसमें क्या होता है? ये जेफरसन फ्रैक्चर कहते हैं इसको. The name is a Jefferson. C2 में there is one more fracture. I'm checking whether I have taken that into account or not. I think so. Yes, it is. अभी C2 में जो फ्रैक्चर है उसमें एंडरसन डी एलांजो का क्लासिफिकेशन है. इन दिस केस यू कैन सी हियर डेंस का पार्ट, अपर डेंस ऑब्लिक 8% का टूटा है. यहां पे देखिए ऑब्लिक में टूटा 8%. वी सी टाइप 1 59% गया, हाई इंसिडेंस रिस्क है, यहाँ पे हाई रिस्क है. बेस ऑफ डेंस गया ट्रांसवर्स में तो 59 गया. एंड टाइप 3 में बॉडी ऑफ फैसेट तक फ्रैक्चर चला गया 33%, 1/3 ऑफ गॉन. इट इज वेरी डिफिकल्ट. सो that classification is what is type 3 de-Alonso classification. But apart from that, this odontoid process के fracture में how it can happen? Can anybody tell me how it can happen? Give me one example. Anybody has asked me some question, I believe. Hangman's fracture. Wonderful, legend. Wonderful. Hanging. Wonderful. क्योंकि जब लटकाएगा उसको तो हैंगिंग में तो ऐसे ही लटकाएगा या लटकेगा, whatever. I mean, don't give me a different this one. But yeah, I mean, hangman fracture. तो ऐसे ही जाएगा. सर ऐसे आएगा, ऐसे जाएगा. तो जो फ्रैक्चर ऐसे जाएगा या जो भी है, तो उसमें क्या होगा? ओडोंटोइड प्रोसेस का फ्रैक्चर जो होगा दैट विल गो फॉर कंप्लीट. प्लीज रिपीट दिस 1 second. साहिल, व्हाट डू यू वांट मी टू रिपीट? Okay. Understood. See, this is the classification ओडोंटोइड प्रोसेस के लिए, एंडरसन डी एलांजो क्लासिफिकेशन. ठीक है, तो इस क्लासिफिकेशन के हिसाब से टाइप 1 में व्हाट वी सी इज द वेरी लेस 5 to 8% ऑफ ऑन टॉप डेंस हैज गॉन. इसमें प्रॉब्लम नहीं है. लेकिन जब प्रॉब्लम यहां बढ़ेगी when there is a type 2, type 3. So it's a difficult, very difficult type 3. So hangman fracture, we say like that. Okay. Anyway, this is how you, when you see, you can find out. So it's again the axial loading also, hyperextension also, Nizin, it's a hyperextension also like this. And then there is a chance of what you say that particular axial loading. जब ऐसे डूबेगा, what you say the diver fracture. Anyway, that is the mechanism. We should not talk much about it. And there is something called इसके बाद भी मैंने रखा है कुछ, हाँ, I think क्या, नहीं, spinous process. Now देखो C7 का spinous process break हुआ है यहाँ पे. This fracture I wanted to tell you, only spinous process has broken. Anybody can name this fracture? If anyone can name this fracture to me, I'll consider you that you are a very good in fracture reading. Any clinician, students, I understand it's difficult. कुछ नाम है इसका, क्लेसोवर्स, C7 फ्रैक्चर स्पाइन का, ठीक है. ओके, अभी हम आते हैं, अपार्ट फ्रॉम दिस whiplash and other things, एक और फीचर पे आते हैं. लेट अस सी दिस फर्स्ट. ओके, अभी आप, there is a fancy, there is a, not fancy, I should not say, there is a scientific term, hyperflexion along with translation. Yeah, hyperflexion translation. In which condition it could be there? Sahil, Megha, Nizin, solvers, Alfia, you are correct. बताइए, which condition hyperflexion translation is seen? Very simple. Just put your mind. फिजियोथेरेपी का दिमाग तो और फास्ट चलता है इस केस में. Whiplash. Okay. I agree. whiplash की एक खासियत है. Okay, ठीक है. whiplash पे I'll come even later. छोड़ो उसको. There is something called spondylolisthesis. All of you know. कहने का मतलब ये रही आपकी vertebral body. ये रहा जी प्रोसेस. ओके, व्हाट आई एम सेइंग यू, हाइपरफ्लेक्शन, अभी ये फ्लेक्स हो गया एंड इट इज अ ट्रांसलेटेड वाज पैरेलल मूवमेंट, राइट. ये तो स्पॉन्डिलोलिस्थेसिस का केस है, whiplash है ना. एंड मेनी केसेस इट इज व्हाट वी से. अच्छा, व्हाट इज द सीट बेल्ट इंजुरी? एनीबडी कैन टेल? You are right. You are completely right what you have said. I'll just check the message again. Whiplash, but same thing, right? Yes. Chance. Okay, chance पे भी आ रहा हूं. 2 मिनट. हाइपरडीनिया 2 मिनट, बस 2 मिनट वेट कीजिए, हम चांस पे भी आएंगे. पूरा सर्वाइकल को फिनिश करके फिर चांस पे आएंगे. दिस इज वेरी इजी फॉर यू टू कनेक्ट इवन द लंबार एंड थोरासिक. अभी क्या होता है, सीट बेल्ट लगा हुआ है तो पहले यू विल बी हाइपरफ्लेक्शन एंड देन इट विल बी ट्रांसलेटेड एक्सियल. ऐसे साइड से देखिए, ऐसा हो रहा है. सो इट्स अ स्पॉन्डिलोलिस्थेसिस टाइप, right? So it actually moves. Vertebra first goes hyperflexion and then move also. Obviously like this, and then ये थोड़ा move होता है, extension होके move होता है, obviously. That's true. Wonderful. अभी इस डिस्कशन को यहाँ पे स्टॉप करते हैं. Now we will talk about another discussion is what? अरे यार, yeah, hyperflexion की कहानी हो गई. See, when I teach X-ray, I will not tell. Ideally, normally, I should not stress more on this mechanism. Why I'm stressing? Because, you know, you ask, being a physio, you always ask the patient, how did you fall? Then they will say, I ask another question. Can you, I ask either what or another. Can you mimic me? How did you fall? If you remember. So they will tell, sir, it fell like this. So when they do like that, when they mimic that, or when, obviously mimic means वो गिर के थोड़ी बताएगा मुझे, but वो बताता है कि सर ऐसे गिरा. Okay, so when I see that, I actually try to find out the picture, like which ligament or which could be hurt, and then I try to correlate with the X-ray or the CT or MRI, whichever I see. CT and MRI separately we'll see. We'll not talk about that. Anyway, today is the fracture. So यहाँ पे आप बोलिए, अब हम लोग जो है यहाँ पे हाइपरफ्लेक्शन, प्योर हाइपरफ्लेक्शन हाँ ठीक है, हाइपर एक्सटेंशन इंजुरी देखेंगे. कैन यू टेल मी हाइपर एक्सटेंशन में कोई ऐसा कंडीशन विच इज वेरी वेरी इंपॉर्टेंट फॉर अ फिजियोथेरेपिस्ट? इज देयर एनी कंडीशन द फ्रैक्चर यू कैन सी हाइपर एक्सटेंशन होने की वजह से? इट्स अ क्लिनिकल कंडीशन. ओके, आई विल नॉट कीप दिस वन, आई विल मेक इट एस. आपने सुना है ना, एंकिलोजिंग स्पॉन्डिलाइटिस, राइट? राइट. सो इसमें क्या होता है? सपोज दिस इज द स्पाइन. ये क्या होता है? ये बंबू टाइप स्पाइन हो जाता है, राइट? इससे ना बंबू टाइप स्पाइन. एंक्लोजिंग स्पॉन्डिलाइटिस पे हम लोग डिटेल में बात किया है, आवर कंप्लीट कंप्लीट दिस क्लास ऑफ एक्सरे, राइट? एस, एंक्लोजिंग स्पॉन्डिलाइटिस, वो फ्रैक्चर ऑफ पार्स इंटरकोलारिस, हाँ वो भी है, बिल्कुल सही है. सो व्हाट हैपेंड हियर? इट इज वेरी टफ, इट्स अ स्टिफ स्पाइन. एंक्लोजिंग स्पॉन्डिलाइटिस, तो एक्सटेंशन होगा तो क्या होगा? टूटेगा ही. ओके, सो वो जो फ्रैक्चर है दैट वी से एज अ हाइपर एक्सटेंशन इंजरी. Okay, so injury के mechanism में when we talk about is a hyperextension injury. So yes, any other fracture का, इस fracture का कोई और नाम है? आप में से कोई कह दे तो I'll be very happy. Any other name, very layman term name? Anybody? Sahil, Nizin, anybody? Megha? Very interestingly, you are taking the class, so I'm asking you. Carrot stick fracture, have you heard of? Carrot स्टिक फ्रैक्चर सुना है आपने? ठीक है, नहीं सुना है तो कोई बात नहीं, आज से जानिए. कैरेटिस्टिक फ्रैक्चर इज व्हाट हाइपर एक्सटेंशन में होता है और एंक्लोजिंग स्पॉन्डिलाइटिस के कंडीशंस में होता है. ओके, ठीक है. अब एक और इंजरी बताइए. somebody was discussing about teardrop injury. उसको हम साइंटिफिकली क्या बोलेंगे? आई थिंक साहिल was talking about teardrop injury. Okay, हाइपरफ्लेक्शन इंजरी जो है दैट इज अ टीयर ड्रॉप इंजरी. क्या हो जाएगा? ऐसे यहां पर अगर स्पाइन है तो इसमें क्या हो जाएगा? इसमें एक पार्ट निकल जाएगा. अभी हम लोग देख रहे थे ना, आई विल कम ऑन दैट. कहां गया हमारा टीयर ड्रॉप? या देखिए, ये वाला पार्ट देखिए, एवरीबॉडी कैन सी, देख रहे हैं ना? दिस इज द टीयर ड्रॉप फ्लेक्शन. ठीक है, दिस इंजरी इज कॉल्ड टीयर ड्रॉप फ्लेक्शन विच इज एक्चुअली द हाइपरफ्लेक्शन इंजरीज. क्लियर है? अरे बाबा, yes or no, anything in chat? I'm audible? Yeah. So, well, जब आप नहीं कुछ बोलते हैं तो मुझे लगता है कि I'm not audible enough. Anyway, so teardrop flexion ऐसा दिखेगा. हम उसको teardrop को क्या बोलेंगे? Basically, it's a hyperflexion. अभी हम आपको क्यों बोलना चाह रहे हैं? These all are the mechanism. Why these mechanism are so important for us? Only and only, हाँ, only and only कि आप जो है ये नॉर्मल लेटम में रह के नहीं फंस जाओ. You should be knowing, you should be revising these all teardrop fracture. So you should be able to revise whenever you see X-ray. You should be able to know अच्छा teardrop है, hyperflexion हुआ रहेगा. teardrop में ना फंसो, you go into the mechanism. Okay, that's the reason मैं mechanism पे ज्यादा जोर देता हूँ. I don't know whether I'm doing like I'm stretching your class or not, but yeah, I mean, I feel this is the best way to let you remember these things like hyperextension. अभी जैसे थोड़ी देर पहले हमने हाइपरफ्लेक्शन ट्रांसलेशन पढ़ा, इसी तरह जो है अभी हम हाइपरफ्लेक्शन ओनली गया, हाइपर एक्सटेंशन गया. तो इससे क्या है, हमें पता रहता है व्हाट इज द मैकेनिज्म ऑफ इंजरी. एक्सियल लॉडिंग हुआ था, ओके, डाइवर इंजरी थी, एवरीथिंग. अब देयर इज अ टर्म, आई विल नॉट गेट इनटू डिटेल ऑफ दिस टर्म. इफ यू नो यू टेल मी, इफ यू डोंट नो आई विल लेट यू नो इन अ वेरी शॉर्ट डिटेल. सीवोरा. Do you know about Seabora? SCIWORA? I think there are certain people on YouTube also. Yeah. Seabora. Spinal cord, मैं लिख ही देता हूं. स्पाइनल कॉर्ड, आई से हो गई इंजुरी. डब्ल्यू के लिए ले लीजिए विदाउट. आर ए के लिए ले लीजिए रेडियोग्राफिक एबनॉर्मलिटी. ओके, आप ये ध्यान दीजिए मैंने क्या लिखा है, स्पाइनल कॉर्ड इंजरी विदाउट रेडियोग्राफिक एबनॉर्मलिटी, यहाँ रेडियोलॉजिकल यूज नहीं होता है, ये रेडियोग्राफ पे है, सारी कहानी ग्राफ पे है। ग्राफ मतलब कि जो भी एक्सरे पेपर पे whichever has come, वो सारी स्टोरी उसी पे है। I will check your message. No abnormalities, spinal cord injuries that we cannot see on radiograph. Wonderful, Fiza. Redmi 90, no abnormalities. Very nice. So radiograph pe we find no abnormality. Very nice. Wonderful. Wonderful. Wonderful, Preeti. I check every one of your names so that you should not think that you are missed in appreciation. Okay. अच्छा, next और भी बता दीजिए एक SCI, इसका मतलब you all rise my expectation. Actually, I mean, I could not have asked you 100%. I would not have asked you maybe, but I asked you by writing because you increased my expectation. Somebody answer. स्पाइनल कॉर्ड इंजरी तो ठीक है ह्यूमेरा रियाज, बट व्हाट आई एम सेइंग यू उसके आगे तो बताइए। स्पाइनल कॉर्ड इंजरी विदाउट radiological evidence of trauma. Okay, अभी जैसे या करेक्ट है राम, विदाउट रेडियोग्राफी एबनॉर्मलिटीज। ओके, तो इसमें क्या होता है, जैसे सपोज कोई ओल्ड मैन है, व्हेन यू टेक एक्सरे एल्डरली पीपल, ओके, सो यू आर ऑलरेडी सीइंग द जॉइंट इज नैरोड, अब आप यू कैनॉट एक्सपेक्ट द नॉर्मल जॉइंट स्पेस, ओके, that could be some narrowing, okay, but there is no abnormality as such. That's a physiologically it is like that. So it is a S. ये आ गया टर्म मेरे दिमाग में, तो आई जस्ट टोल्ड यू, अदरवाइज इट हैज नथिंग मच टू डू विथ दैट। तो ऐसा है। नाउ विल कम ऑन दैट पिक्चर अगेन, थोड़ा सा इसको और जानेंगे हम इस चीज को थोड़ा सा और, बिकॉज दिस इज समथिंग इंपॉर्टेंट। आई विल रब सम ऑफ दैट। Next week, we have a neuro rehab in GATE. So those who are not registered yet, please register for the next Sunday class. We keep bringing at least thrice in a month for you a lot of important things. As I told you, the students, it's always free. And electrotherapy e-class is also starting. Another 20 minutes will take for the spine. I cannot shorten it. That's the problem. Because thank you, Said. So what was important? I'm moving from the cervical to thoracic and lumbar, so it will be very easy for you. So all of you know the zones of spinal trauma. ठीक है, मुझे कोई बताएगा through chat or anything, can you answer which is the most safe zone of the spine for trauma? Which is the most stable? I mean, I'll put in a physiotherapeutic dictionary. Which is most stable out of all zones? Cervical, thoracic, lumbar, sacral. सबसे ज्यादा कौन है stable? The dorsum spine, the dorsal spine is the most stable, as you all know, thoracic, yeah. And in this case, if you why it is so stable, because this is a, if you see this, it is a kind of transition zone. नेक के लिए और बैक, लोअर बैक के लिए क्या है, एक तरह का ये ट्रांजिशन जोन की तरह से यूज होता है, राइट? सो ये ज्यादा स्टेबल है। ओके, नाउ नाउ वी टॉक अबाउट, अच्छा ठीक है, लेट अस रिवाइज लिटिल बिट अबाउट द सीवीजे। किस में ज्यादा कॉमन है सीवीजे? एनीबडी? चिल्ड्रन, राइट? एंड C2 to C7 vertebra, most of the cases. I'm just revising you so that hyperflexion, ठीक है? डॉर्सम वर्टिब्रा के लिए मतलब डॉर्सल स्पाइन के लिए ज्यादातर कैसे केसेस होते हैं? इट इज ए स्टेबल वन। सो स्टेबल वालों के लिए ज्यादातर जो होता है कंप्रेशन फ्रैक्चर इस टाइप के देखे गए हैं, राइट? डोंट हैव टू डू एनीथिंग एल्स। सैक्रम के फ्रैक्चर कैसे होंगे? से फॉर एग्जांपल सैक्रम के फ्रैक्चर हैं, वो कैसे होंगे? मोस्ट ऑफ द टाइम एक्सियल लोडिंग से होंगे। ओके, सो दीज आर द स्मॉल पॉइंट्स व्हिच यू शुड ऑलवेज कीप इन द माइंड। ओके, नाउ लेट अस कवर। सो डीएल स्पाइन की बात होगी। लंबार स्पाइन का भी ज्यादातर फ्रैक्चर हाउ इट कम्स, द एक्सियल लोडिंग। ओके, एंड सीवीजे स्पाइन where it happens more, as we spoke now only, children. Okay, and okay, what I wanted to, डिस्क इंजुरीज विच लेवल पे ज्यादा होती है? किस लेवल पे ज्यादा होती है डिस्क इंजुरीज? लोअर सर्वाइकल रीजन। If you talk about cervical, lower cervical region is the more prone for the disc injuries, right? So there is a scale. However, I will not get into that scale because that is a matter of radiology and orthopedics, most of that. So we are not into that. But TLIX, okay, TLIX जो है ना, ये एक scoring system है. इस scoring system में we check what is the severity of injury and as per the and X-ray क्यों TLIX, why TLIX का detail क्यों आया इधर? एक मिनट, आई विल चेक योर मैसेजेस। L5S1, okay, well, every one of you have answered. So why the detail came? Because TLIX का ना क्या है, there are three parts in TLIX. There are three parts in TLIX. Okay, so इस three parts में क्या है? पहला ही part जो है ना, what is the morphology of fracture? Fracture दिखता कैसा है? Morphology of fracture. So because of those radiograph term only, I discussed that TLIX. I'll not get into details. So morphology of fracture. Second part इसका और आता है, there is something called PLC. We are going to discuss now. Posterior ligament complex. Okay. Third thing is, okay, PLC. इसका क्या हिसाब है? मतलब what is the integrity of that? How much it is disturbed? And third आता है any kind of neurodeficit, neurological deficit. समझ गए आप? So these three are the part of TLIX. Depending upon the scoring system, we decide what is required. Okay, अभी इसको छोड़ देंगे. One question I'll ask, or should I will not ask anyway, leave it. First, I will go into that, otherwise you'll get delay much. Yeah, see, this is the Dennis column. Okay, Dennis column is very very important क्योंकि ये जो morphology of fracture we were talking about, no, ये इसी से हम देखते हैं. एकदम आपको पूरा लाइफ के लिए याद हो जाएगा. Okay, so this is the Dennis column. You all can answer if you know in this. So Dennis column में क्या है? Column number 1 anterior के लिए, column number 2, column number 3. 1 2 3 मैंने किया है. It is nothing like a hard and fast rule. Column number 1 अगर आप देखेंगे, this is the anterior column. Okay, it is having anterior longitudinal ligament. It has anterior annulus part of the disc. क्योंकि disc आपको पता है, it is a structure which has which is a 90% water inside. I mean inside वाला structure में what you say as a nucleus pulposus, आगे वालों को बोलेंगे आप annulus. Okay, so anterior 2/3 of this body is with this 2/3 of vertebral body as well with the anterior column. Now middle column में क्या क्या आता है? Posterior 1/3 of the body. और क्या आता है? Posterior longitudinal ligament. और क्या आता है? Posterior part of disc जो annulus का part है. ठीक है? Now third column में, third column very important. Third column में क्या क्या आता है आप देख लीजिए. Posterior एलिमेंट्स जितने भी हैं लाइक पेडिकल्स, फैसेट्स, लैमाइना, स्पाइनस प्रोसेस, ये सब जितने भी यू कैन सी. ओके, और पोस्टीरियर लिगामेंट्स भी. पोस्टीरियर लॉन्गिट्यूडिनल लिगामेंट नहीं, supraspinous ligament, interspinous ligament, what do you say, ligamentum flavum, ये सभी, ठीक है। अब डेनिस ने ये 3 कॉलम तो दे दिए, इस कॉलम के हिसाब से we need to decide. Somebody was talking about some time back the burst fracture. Yes, I'll come into that. Just mechanism of injury देखेंगे and we'll see the fracture. Things are done. You'll be able to understand. So कल को आपको ये दिक्कत नहीं होगी। लंबार स्पाइन फ्रैक्चर को मैंने दिखाया। Yeah, this particular part, I wanted you to have a look on that. More than that, in fact. So in a nut, if we see, in a nut नहीं बोलना चाहिए, nut cell है, I don't know how it became. In a nut cell, when we see a compression fracture, okay, compression fracture ka there is a, I have taken this image with the definition, you can see that, but more than that we have to understand collapsing as a result of pressure or degeneration of the spine bones. Abhi kya hota hai, this you can see the white line, all of you can see the white line, ye fracture ho karke nothing has moved more than this body, so we will tell that compression fracture. Clear? Acha, if I ask you, please answer me through the message. What is the prognosis of compression fracture? Any one of you, please come. What is the prognosis of compression fracture? क्या करना पड़ेगा? मैं तो फिजियो हूं ना, मतलब मुझे पूछना पड़ जाता है कभी-कभी. I'm just asking that. Any one of you? What is the prognosis of compression fracture? Someone answered. Good, good, good. Seriously good. सही बात है. Thank you, Booby. Thank you for answering, all of you. So, क्यों good है? Because वो तो कहीं गया ही नहीं. Yes, Preeti. So, it has not moved anywhere. Spinal canal is saved. Ligaments are saved. Disc is not hampered. Itself, body is only hampered. तो prognosis is really good. बोल दीजिए पेशेंट को, रेस्ट कर लो, जुड़ जाएगा. बस, nothing much. Okay, and of course we need to check out the like a series of X-rays just to find out how much it has healed and what all things to be seen depending upon the age also. A lot of factors. Anyway, वो छोड़ दीजिए treatment वाला part. Now there is something called the burst fracture. I will not come into the wedge now. I will come into the burst directly. Why? Because compression and burst are more important. Wedge वगैरह वाला part जो है वो तो आप समझ जाएंगे. बता दूंगा मैं आपको. पहले आप देखिए burst में क्या होता है. One component, you could see that one component moves toward the canal due to axial loading. कहने का मतलब axial loading through the vertebra. If load passage, तो एक जो है टुकड़ा, one part, it actually goes toward the canal. ठीक है, यहां पे देखिए this piece, it can hurt the canal. All of you agree? So this is the burst fracture. Extremely compressed spine. मैं बोला ना, कूदेगा, जमीन पर कूदेगा, चोरी करके भागा है, तो जैसे ही जमीन पर कूदेगा, जैसे ही कूदेगा, all the pressure, see? Okay, so it's axial loading, extremely compressed and crushed. So what happened? कुछ भी segment, it can go and hurt the spine badly. So this is the burst fracture. Okay, wedge में कुछ भी नहीं. Wedge में क्या होता है? It results from the degeneration of spine and trauma. इसलिए I didn't like to talk because we are talking about trauma rather than degeneration. Anyway, ठीक है. तो अभी आप देख रहे हैं तो वो भी देख ही लो. Wedge result from degeneration of the spine and trauma. Okay, इस पर अभी हम चर्चा नहीं करेंगे. What are we going to see? The most important is, which is not there in the image, is something called chance fracture. Somebody spoke some time back about, I think mentioned, I don't know who, but chance fracture. Now the chance fracture comes in picture. As a scientific term in physiotherapy, what we will see the chance fracture. अभी पहले मैं आपको बता देता हूं हो कैसे रहा है. Say for example, this is the body and this is the posterior process. I'll check your message. ओके इस केस में क्या है, फ्रैक्चर इज थ्रू एंड थ्रू, पूरा टूट के बिखर गया है, ठीक है, पूरा। इसको हम उस समय भी डिस्कस कर रहे थे ना, सीट बेल्ट इंजुरी, दिस इज द सीट बेल्ट इंजुरी। ओके लगा जैसे ट्रॉमा आया, मैकेनिज्म इज लाइक दिस, हाइपरफ्लेक्शन एंड देन डिस्ट्रैक्शन। ओके हाइपर एक्सटेंशन डिस्ट्रैक्शन वाज डिफरेंट, वी प्लस, अभी hyperflexion and distraction. So somebody wrote flexion and distraction, okay, but better to go more precise and use the term hyperflexion distraction, because movement and physics is our story in physiotherapy. So use this term hyperflexion distraction, ठीक है। थ्रू एंड थ्रू फ्रैक्चर, चांस फ्रैक्चर, सो आप समझ गए स्पाइन के फ्रैक्चर ऐसे। नाउ इफ यू वांट टू चेक सम ऑफ द फ्रैक्चर, you can see the lumbar, you can see the fracture, all those things when you check. Yeah, so 75% fractures are compression fractures incidence wise. Okay, T12 to L2 60%, but 90% from L1 to L4. Okay, and 20% are fracture dislocation. Okay, यहाँ पे देखिए आपका है फ्रैक्चर, ऑलरेडी हुआ है एक फ्रैक्चर। Okay, compression, sorry, this what you say in old is wedge fracture. Yeah, so this is how you have to differentiate. अगर आपको ये कॉन्सेप्ट समझ में आता है, आई एम टॉकिंग अबाउट दिस कॉन्सेप्ट, ओके, कंप्रेशन क्या है, बर्स्ट क्या है, चांस क्या है, and then of course wedge क्या है. So these three, compression, burst, chance, if you know the mechanism, you can handle most of the cases in terms of radiographic findings. Is it okay? Is it clear with everybody? Okay, so हो गया सब? Thank you, Sahil. Thank you, Sahil. So now we will break for 5 minutes, just 5 minutes, and then we'll start our chapter on the lung. So these things what we explained, I thought to go with very short and brief for spine, so that I can cover the lung as well, because there was many messages to me, sir, last time I think lung I covered well, no doubt. Last to last time wasn't covered well, so at least lung, how to identify those checklist and all, I could not clarify very well. So yeah, this time we'll talk about the checklist also. So we will break for what is the time now? 11:46. Oh, लगभग 2 घंटे लगी गया almost. Okay, so we are going to break for 5 minutes. We are meeting here at 11:53, 54. Okay, so see you, sir. 6 minutes of break. So in a minute, we'll start.
Yes, sir, please.
So once again, we are on it. Yeah. So you can see certain of the fracture image. Surgical anatomical neck fracture. So these all, like, if you join the complete class, like, we have a very big detail on all these, like joint by joint, bone by bone, either with the fracture, osteomyelitis, bony cancer, I mean the bone cancers, like your osteosarcoma and everything. So I have discussed everything in my those classes in minute detail. Apart from that, nutritional disorder, the disorders, there are many disorders like age-related disorders. Everything has been described in very detail of all those class. Like, you'll get slides for everything, you'll get matters for everything. So shaft of the humerus, you can see the fracture here. So I have selected some of the image from my earlier class. This is the typical X-ray of elbow dislocation. So this is very popularly proximal radioulnar fracture, including dislocation. You could see that. And this is a Monteggia fracture. Distal radioulnar Galeazzi fracture. Both are contrast. So these all are small. You can see scaphoid and trichotrom fracture also. So these are the small, some of the radiograph image I have taken just for your reference. Yeah. Now this is a question. Who will answer me? What is associated here? ये जो white दिख रहा है, what is this? After break, someone answered metal. Nice. Bony fragments. Lakshmi ji, no. It is not bony fragment, because in earlier slides when we were talking about the radiographic densities, you remember when we were talking about radiographic densities, there was something called white, and more than white, very white. Apart from that, there is a bright white also. Okay, so what happened? Bone is white, है ना? But very white. ये आपको क्या लग रहा है? जितने भी pieces हैं, this is much whiter than the bone. And the bone, you have a lamella and all. You can see cortex is more white. Of course, this is a solid, but आपको ये पूरा का पूरा white ही लग रहा है. देखिए, everything is like a star kind of white. So this is a metal piece or gunshot injuries, है ना? Calcification, very white is calcification, but calcification का pattern तो ये नहीं है ना? Is this the pattern of calcification? Please tell me. Can it be? No. Calcification का pattern जब भी होगा, it will be related to among the tendons, like something like a horse riders के लिए होता है, among those quadriceps tendons that develops. तो उसका pattern ये नहीं है. And other things, as you asked about calcification, so let me detail that calcification का क्या है ना. First of all, we need to check for the calcification एक तो मुझे पैटर्न देखना है, हमें क्या करना है, पैटर्न देखना है, पैटर्न क्लासिफिकेशन का है नहीं। देन पैटर्न से भी पहले हमें साइट देखना है, साइट से बहुत बड़ी स्टोरी जो है ना, इट विल गेट क्लियर साइट से ही। देन वी हैव टू सी पैटर्न, okay, sight and pattern, and after that we need to check the contrast. As you rightly said, in terms of contrast, yes, it is that way, white. But if you check the pattern, it doesn't look like that way. But anyway, sight wise, okay, but pattern wise, no, it is completely fragmented. So fragmented pattern of calcification is not common. Now intertrochanteric fracture, you can see one of the fracture, and apart from that you can find the femoral neck fracture. So these are the very small kind of very small introduction of these things. There's an ankle fracture, you can see normal foot is like that, calcaneal fracture is like that, there is something called Bowler's angle. So all these angles I have detailed a lot in my own this course, like how you have to measure those angle, and that angle we decide whether it's a fracture or not. Because calcaneal bone, if you see, this is the bone. Calcaneum bone is something, you know, which takes about 2/3 of body weight. So agar yahan pe fracture hoga, the line will be discontinued, the imaginary line passing through this. So, you know, depending upon that, we check the angle, how the angle is changing. Agar wo angle change ho raha hai, why? Because fracture is there, so it will go for more flat, so angle will reduce. So all these things we have discussed there much detail for you today. It was just a reference images. Apart from spine, depressed fracture, these all are osteomyelitis, osteoarthritis. So these all are the glimpse of what we study in those courses: osteoporosis, osteopenia, arthritis, how to identify grade 1, 2, 3, 4, hip fracture, many a times, you know, unidentified sacrum fracture, ilia, this all osteoporosis, then scoliosis, lordosis. So all these things are in a big detail when it comes to our complete X-ray class. Anyway, now let us have certain spotters for lungs as well, because lung was last time not. Just 1 minute. Yeah. So lung was last time, as you are like last time, it wasn't done so well. So okay, it was very fast because spine only took some more hours, 3-4 hours. Okay. Now, yeah. So normal lung X-ray, you know, to know the abnormal, we need to first know the normal. So the normal X-ray, I'll check your message, don't worry. Okay. See, Sai wanted to know about Cobb's angle. Most tilted superior vertebra, most tilted superior vertebra, most tilted inferior vertebra. The angle between them, Cobb's angle. Okay, Cobb's angle is something, the curvature, that curvature we need to find out in spine in case of scoliosis. Sai wanted to know about it. So take an X-ray paper, take a pencil, and you can easily see in the image. Okay, and depending upon what is the angle, you need to take the, you need to make the plan of the treatment as per the value of angle. Recently, one of my patients, she is suffering from SMA, spinomuscular atrophy. The 13-year-old girl, 12-year-old girl, she underwent surgery for scoliosis. So it's not just the normal man who get scoliosis and get operated, but most of these surgeries are even for the neurologically dull people, neurologically impaired people, especially SMA and other things. And I have seen other SMA kids also undergoing this surgery. So, her corpse angle was more than 70 degree or 75 degree. No, I think it is more than that. I have forgotten the report, but it was much more. And the surgery was indicated some time back, but only due to her comfort of getting the summer vacation. Now the surgery has been performed. However, after surgery, she is okay. She is better. Purpose is solved. So corpse angle is having importance in planning the treatment of a scoliotic patient. Now, normal X-ray of the lung. So normal X-ray of the lung, you need to check to know the part. So this particular image I have taken from somewhere. In this, you can see black part of the lung. I'll come into that. That is the air. Okay, complete lung. So, you have to check the position of trachea. Okay, I'll tell you which all things to check. First, you see the position. This is the trachea, and then you have a C7 spinous process in the lung. This is the border of the heart. The image of the heart, you can see here how you can find out here. And then you have a hilum. Who will tell me which is higher, left hilum or right hilum? Left hilum is higher or right hilum in a normal person? Anyone? Answer. You have still 1 minute of time. I don't know, most of you answered the right, but it is the left which is higher. Yes, left is higher. Okay, anyway, we'll come on that later. So aortic node, then you have an arch of aorta. So you can see the schematic diagram of heart, sitting here. Why I'm showing you the schematic diagram? Because you'll be able to know. So to see the diaphragm is down here. Okay, and this angle is very, very important. I'll come on that in detail why. And then you have a stomach here. Stomach obviously you can't see, but you can see the gastric bubbles, very important. Okay, this is something called the costophrenic angle. Okay, this is the diaphragm. Okay, and then you have a down, of course, inferior vena cava, obviously superior vena cava, not so significantly seen in X-ray. You need to find out the border. More than normal, it is abnormal. Okay, you can see the most importantly, you could see the lobes of the lung. This is the lobe of the lung. Okay, upper, middle, lower. Lower को इतना छोटा नहीं समझिए, अगर हम PA view में देखेंगे तो it will be too big. Okay, and you have a manubrium, superior vena cava, and then right main bronchus, horizontal fissure, the fissure which divides the lobes. Then you have a oblique fissure which divides the lower lobe to the middle lobe. Okay, left lung में तो middle lobe का बात है नहीं. So that is how it goes. Story goes like that, and we'll come on this image again and again as and when necessary. Now come PA and AP view. Can you tell me why AP and PA makes a lot of difference in chest X-ray? All of you know about it, AP and PA view? Why it makes a lot of difference? I have anyway presented the striking difference between them, but why? Yeah, Gopinath ji, please tell. How? सपोज अभी क्या होता है, सपोज अ पर्सन इज सिटिंग, सॉरी स्टैंडिंग, ओके, ये इसका एंटीरियर है, ये इसका पोस्टीरियर है. व्हाट आई एम सेइंग यू, if you take x-ray from this side, ask any x-ray technician, if you take x-ray from this side, heart will be enlarged. Okay, because x-ray का जो बीम है ना वो ऐसे निकलता है, करेक्ट है? Obviously it's not a particle, you cannot say that, it's not a wave always. No, I'll come on that, watch side, I'll come on that. So क्या होता है ना, suppose this is lung area, suppose this is a lung area, so in this case the heart is more seen, okay, but when it comes to posterior part, you know, the lung is properly seen, even the lower lobes completely, and the heart is seen in a small like a very prominent size, very nice size, okay, correct size anatomically. So PA view में क्या होता है, erect and standing, supine and flat. AP view, not possible to have PA view. Then heart, it is not magnified, I told you, it is here, it is magnified. Diaphragm, इसमें lowest रहेगा, इसमें आपको higher दिखेगा diaphragm, you know, this is another problem. Stomach airfield seen, so any x-ray bubble, I'll show you that how you see the gas bubble. If you see, then you find out it's a PA view. Only air will be seen, okay, no fluid part. And scapula, it will be away, but it will be lying on the lung fields, okay. Clavicles, PA view में लगेगा आपको कि lungs filled पे है, because this is how it is taken. And but here if it is AP view, it will be what? It will appear it is above the lung field. Now here deep inspiration is important, here inspiration is important, and deep inspiration and expiration is important, for matter of fact, in PA view. And for lung details, okay, always remember, for lung details we always prefer PA view. And why AP view is also important? For bony details, because bone बहुत अच्छा दिखता है उसमें, okay, you can find out the fracture, you can find out the displacement, you can find out the any other bony abnormalities. We are coming on that. So if you know these 4-5 slides properly, if you know among these slides, if you know these points properly, you are set to read the x-ray. I have brought 4-5 x-ray films also for you digitally, you can just see, and we'll discuss on that how it works. Okay, so right now we have a 10-point checklist. We'll come on the checklist again later, but first what you have to find out, either it's a PA film or AP film. आपको lungs देखना है, PA देखिए, bones का problem लेना है along with lungs, तो AP में भी आना पड़ेगा. Okay, अभी it is a satisfactory inspiration. Small inspiration can cause the heart appears larger, you know, vessel crowding mimicking infection at base, vessels mimic होते हैं. Okay, and if the patient is rotated, अभी क्या होता है, कुछ पेशेंट ऐसा होता है, मतलब लेते समय अगर टेक्नीशियन इफ doesn't say, it will be like this, little bit rotated, so उसका you cannot have a proper x-ray in that case. How to check the rotation part, that we can discuss later, no problem. But right now I can tell you, rotation is always creating problem. I don't know whether I have taken today any rotation radiograph. I think I have taken one rotation. I'll find out for you one rotation radiograph and get you if it is important. So अभी दूसरा क्या देखना है, both domes of diaphragm should be clearly seen. Okay, lower lobe diaphragm, both the domes should be clearly seen to understand pathology. Just 1 minute, I'll connect it. There's some disturbance. Yeah. So, and after that, is the heart really enlarged? Okay. So we have to check the CTR. We will let you know. I mean, we will discuss about CTR, cardiothoracic ratio, how to find out. Okay, on radiograph. Then are the heart borders clearly seen? If there is a heart border not clearly seen, that means what? I'm not asking. I'm just creating the curiosity in you. Okay, if the heart border is not clearly seen, that means there is some problem. The heart border should be clear. Are the hilum normal in position? Hilum, I'm talking about size, density. Left hilum should be level or the higher than the right, never lower than the right. I don't know. Why did you write the right or normal? No, it's and the level only. Are the bones normal? Okay. Check the tricky hidden areas like lung apex, superimposed over the heart, pericardial region, around each hilum, below the diaphragm. Ask yourself whether particular clinical condition of patient is addressed or not. So these all are the kind of checklist. Okay. So we will decide, we will actually go one by one and then we'll see. Okay. To make it more concise, I have brought this also for you, A to I specific checklist. You have to find out airway, bones and soft tissue, cardiac signs, silaute, retrocardiac density, diaphragm, edges of heart, fields and fissures, great vessels and gastric bubbles, hilum instrument. If you see, this is a kind of mnemonic. I don't believe in theory of mnemonics, but yeah, I mean, it's good. If you can remember, then nothing like that. So A for airway and likewise, you can see right from A to I, there is a checklist. At least you can remember this. This will work for you whenever you want to see an X-ray. So these things you are able to check in the X-ray. Okay. Instruments. Okay. Someone is asking me. You can always message in the Zoom chat if you're not connected to Zoom. Okay. Connected to. Okay. No problem. No problem. So I is nothing as an instrument, sometimes the intercostal drainage is there and all those things are there. And so these kind of instruments can be seen here. Okay. So for that purpose only it is. So what is the review area? Very simple. I have brought everything for you, which is very simple. Okay. So what you have to see? You have to check episis. Episis for the pneumothorax, tumor and cervical rib. Okay, forget about the condition right now. Check episis, apex, okay? And then outline all the bones. Able to outline all the bones, like clavicle. Okay, if it is a PA view, the scapula will be away and you are able to see the ribs. Okay? Just 1 minute. I'm sorry, disturbance. So like outline all the borders, all the bones. I'll come on that later. Yeah. Outline all the bones. Okay. Now we will check about the AP window. Okay. I'll come on that later if it is required. You feel Carana angle. Okay. Assess azygous contour. Check pleural, check lung periphery for what? Pleura. I answered right. हम लोग वो भी देखेंगे some pleural disorder like pleural में कैसा दिखता है, how to identify the pleural disorder from the interstitial lung disease like that. So we can check that. Assess heart border. Okay, I'll ask certain questions also from cardiopulmonary physiotherapy. So you have to answer. Check and compare the hilum position, density and morphology. Hilum का position डेंसिटी मॉर्फोलॉजी देखना बहुत इंपॉर्टेंट. इज द डेंसिटी बिहाइंड द हार्ट द सेम ऑन द बोथ साइड और डिफरेंट? दिस ऑल्सो टू चेक. एंड देन ऑफ कोर्स अपार्ट फ्रॉम दैट सॉफ्ट टिश्यू चेक होना ही होना है. Okay, is there any swelling or something like that? Can you see diaphragms clearly or not? Can you see ये वाला एंगल कोस्टोफ्रेनिक एंगल क्लियरली दिख रहा है या नहीं? अगर ये थोड़ा भी यहां तक वाइट दिखता है तो there is a, anybody will answer me, what is that? अगर कोस्टोफ्रेनिक एंगल is not clearly seen, that conical part is not seen, that means what is that? लोअर लोब में नहीं शायद हाइपर इन्फ्लेशन प्लूरल एफिजन. यस यस बूबी. देखो हाइपर इन्फ्लेशन इज बिकॉज ऑफ व्हाट? इट इज बिकॉज ऑफ एयर, राइट? इट इज बिकॉज ऑफ एयर. एयर का कलर कभी भी व्हाइट नहीं होगा, इट विल बी ब्लैक. और आप जो आंसर कर रहे हो शायद दैट मे बी यू आर आंसरिंग कंप्लीटली दैट, यू नो, लाइक कंप्लीटली द लंग filled, वो मैं नहीं पूछ रहा. I'm asking only this part. It has to be very conical. और वो conical में क्या होगा? We need to check the particular, like, contour is very clear, the diaphragm is very clear, the pleura is coming in a proper way, in a normal way. Okay, अभी somebody said gastric bubbles, वो अलग है, वो हमें diaphragm के नीचे देखना है. ओके, गैस्ट्रिक बबल्स है या नहीं. मोस्टली पीए केसेस में, पीए वाले व्यू में, पीए रेडियोग्राफ्स जितने भी हैं, यू विल बी एबल टू फाइंड दैट. ओके, सो दीज ऑल आर द रिव्यू एरियाज, एटलीस्ट दिस, बट नॉट लिमिटेड टू दिस, इट कुड बी मोर. ओके, चलो अब कुछ और करते हैं. या ये जो ABC है ना, आप देख रहे हो ना, दिस इज इंपॉर्टेंट. यू नो, व्हेन द एक्सरे कम टू यू, आप अपने अंदाजा से ही लगाता हुआ, पहले तो आप ये देखो, आप फाइंड आउट करोगे कि दिस पर्सन हैज अ लिटिल टिल्टेड, हाउएवर हिज एक्सरे इज नॉट रोटेटेड, लेकिन इसका थोड़ा पोजीशन का प्रॉब्लम तो है. ओके, एक्सरे इज नॉट रोटेटेड, व्हाई? बिकॉज एक्सरे रोटेशन के लिए क्या देखते हैं? C7 देखते हैं, वेदर दिस आर इक्विडिस्टेंट फ्रॉम बोथ द साइड और नॉट. सो ये सब छोटे मोटे चेक्स हैं, वो आपको रोटेटेड एक्सरे नहीं मिलेगा. आई एम जस्ट टेलिंग यू, वो टेक्नीशियंस आर वेरी स्मार्ट, हार्ड वर्किंग, दे ऑलवेज टेक अप बेस्ट ऑफ रेडियोग्राफ्स. सो अभी क्या होता है? अभी आप नीचे देखो, इस मिड लाइन से हार्ट का बॉर्डर राइट साइड, हार्ट का बॉर्डर लेफ्ट साइड, ये R होता है, ये L होता है, राइट राइट, और ये लेफ्ट हमेशा यही रहता है, राइट. और ये टोटल फ्रॉम दिस एज टू दिस एज लेट अस टेक एज अ C. सो थ्योरी सेज A प्लस B डिवाइडेड बाय C, जो रेशियो होगा, A प्लस बी डिवाइडेड बाय C का जो रेशियो होगा, वो कभी भी 0.5 से ज्यादा नहीं होना चाहिए. ठीक है, कहने का मतलब वाई A प्लस बी डिवाइडेड बाय C, कहने का मतलब ये टोटल डिस्टेंस A प्लस बी हो गया डिवाइडेड बाय C. ठीक है, दिस इज कॉल्ड कार्डियोथोरैसिक रेशियो. तो कार्डियक कितना बड़ा है कंपेयर टू थोरेसिक के, दिस इज वेरी इंपॉर्टेंट. नाउ A प्लस बी का जो पार्ट है, जो हार्ट है, वो हार्ट if it is taking more than 50% of total thoracic space, then there is a, क्या है प्रॉब्लम? हार्ट का एनलार्जमेंट है, इट्स अ हाइपरट्रॉफी. Am I sounding logical, all of you? Cardiomegaly, yes, cardiomegaly, yes, it's a cardiomegaly. इसीलिए मैंने कहा दिस इज वन ऑफ द मोस्ट इंपॉर्टेंट कॉन्सेप्ट. A प्लस बी बाय C आप हमेशा देखिए, इट शुड बी लेस देन 50%. इतना समझ में आ गया? ओके, सो नाउ लेट अस डिस्कस वंस अगेन द चेकलिस्ट एंड वी शुड अंडरस्टैंड दैट. ओके, आइदर इट्स अ PA और AP फिल्म, पहला चीज ये पता कीजिए. सेकेंड चीज क्या है? Whether it's a satisfactory inspiration, Is because a small inspiration can cause what? Small inspiration में क्या होगा? Just see here. Small inspiration, yes. See, if it is aspiration is small, lung will not inflate properly. So क्या होगा? Heart का size तो नहीं differ होगा ना? Lung size is differed because of the air going inside. Heart का size तो बहुत differ नहीं होता है. So what is the main thing? If lung is not inflated properly, A plus B by C का ratio जो होगा, that can go more than 0.5, which will be pathological, unnecessary. So it is a false pathological. ये एक नया problem हो जाएगा. इसलिए हमको वो risk ही नहीं लेना है. So you understand my point? So this is how we need to check. Okay? अभी देखो. Inspiration is so important. Patient is rotated or not? Rotated में भी क्या होगा? It will not seen properly. एक border दिखेगा नहीं, दूसरा border of heart दिखेगा. एक diaphragm domes will be up and down. अभी देखो, when we will discuss now in some time the conditions. तो क्या होता है? Suppose this X-ray is rotated. All of you see. So क्या होता है? X-ray अगर rotate हुआ, so this will go higher and this will go significantly lower. Okay? So that shows another problem. That shows यहाँ पे कुछ problem है. Collapse है, consolidate है, क्या है? That will come to see. Collapse है. Okay? वो एक अलग problem है. So rotation नहीं होना चाहिए. Now you understood the checklist. Why did I go back and got you understood? Okay. Now, both domes clearly seen pathology in adjacent lower lobe diaphragm. Okay, so both domes of I'm talking about the diaphragm is clearly seen or not. देखिए आप, it should be clear, both domes. Okay, next, और चेक कीजिए, is heart is enlarged? अगर if you have a very good inspiration, the patient is sitting properly, X-ray report will come to you is largely normal. So in that case, if heart is more than what we understood, cardiomegaly, so that should not be there. Are the heart borders clearly seen? If it is not there, suppose the heart borders are not clearly seen. Say for example, in this, heart borders are not completely clearly seen. Okay, arch of aorta में could be problem. Great vessels में problem हो सकता है for the heart. Okay, so heart के borders को देखने के लिए heart के vessels को चेक करना ही करना है. Okay, heart borders को basically, borders को चेक करना ही करना है. Hyla, normal in position, side, density. If I go more detail, can you see here? Actually, pulmonary artery, pulmonary vein जो यहाँ पे V-shape structure बनाते हैं. All you know, the hilum में structure V-shape होता है. ऐसे होता है ना hilum में. And left is little higher or in normal to the right or maybe little higher. Okay. Suppose, I'll come on that conditions later, but suppose ये part आपको white दिखता है. So there is a pathology. Very simple. There is a pathology. It's a radiolucent. Sorry, radio opaque. So this is how the checklists are important. Asha, all the bones are normal. Yes, you have to check the bones. Suppose I'll erase this, and then if you find out the bone part, अगर आप AP व्यू लेगा तो bone will be clearly seen. Okay, अभी आप कोई rib fracture का केस है, say for example, so you can easily see bone are continuous or not. You'll find it. If it is not continuous, you'll find it. And you can see the clavicle if it is there in problem, menubria, sterni, जिफी, everything you can see here. The bones के लिए best है AP view देख लीजिए, आपको बहुत कुछ पता चल जाएगा उसमें. Okay, so bones are normal or not, it's very important to find out in AP view. It's very good, and bones के लिए ही AP view is good. Okay, lung field देखना है तो always PA view. Very nicely seen. Full black रहना चाहिए. Okay. Now, so and then check the hereditary areas like lung apex. हार्ट के ऊपर जो रेट्रो रीजन जो भी है हमारा व्हाट वी से रेट्रोकार्डियक रीजन जितने भी हैं उसको देखने के लिए अराउंड इच हाइलम बिलो द डायफ्राम ऑल दिस थिंग्स एंड आफ्टर दैट इतना तो देख लिया लेकिन जिस प्रॉब्लम के लिए पेशेंट का देख रहे तो पता चला भी है नहीं सो वी हैव टू फाइंड आउट वेदर द प्रॉब्लम वाज एड्रेस्ड और नॉट प्रॉपर्ली ओके फाइन अभी आप स्पेसिफिक चेकलिस्ट में अगर आ गए तो आपको देखना है तुरंत पता करना है कैसे करोगे पता अरे एयरवे देख लिया ब्लैक है हाँ ठीक है इज देयर एनी पैच देन विल फाइंड आउट वेदर इट्स ILD और इट्स बिकॉज ऑफ एनी प्लेउरल एफ्यूजन और समथिंग दैट विल डिस्कस नाउ एंड देन इसका बोन्स बी से बोन देख लिया सॉफ्ट टिश्यूज भी देख लिए उसके साथ जस्ट एन निमोनिक सी से कार्डियक साइन इसमें सिलौटे देखेंगे हम सिलौटे कहने का मतलब कार्डियक सिलौटे कहाँ आता है यू कैन चेक इट हियर इट शुड बी हियर सिलौटे साइन के लिए बहुत आई हैव डिस्कस्ड अ लॉट इन आवर नॉर्मल क्लासेस यू कैन सी हियर सिलौटे साइन दिस इज कॉल्ड कार्डियक सिलौटे ओके इट कम्स इन द मिडिल लोब के रेंज में आता है वो सारा तो दिस इज हाउ you have to find out see से cardiac signs जितने भी हैं relative cardiac density everything you find out then you find out that D for diaphragm diaphragm का क्या condition है whether you are able to see the costophrenic angle properly or not see I marked it here that time costophrenic angle अगर मैं इसको erase करके बोलूं तो like see how nicely it is seen here costophrenic angle देख रहे हो ना आप लोग because this is very very important okay यहीं पर अगर white टाइप का फ्लूइड भर जाएगा तो क्या बोलेंगे इससे फ्यूजन राइट सो वो चीज बहुत ध्यान देने वाली बात है द एंगल इज सीन और नॉट ओके नेक्स्ट में आप जब देखोगे तो एजेस ऑफ हार्ट डायफ्राम डी फॉर डायफ्राम मतलब डायफ्राम का हर चीज लेवल ऑफ डॉम्स कोस्टोफ्रेनिक एंगल इट इज क्लियरली सीन और नॉट हाउ मच हाउ इट इज शोइंग ओके सो वी हैव टू फाइंड आउट द कंडीशंस आप जब तक जो है ना एक बात मैं आपको हर लोगों को बोल देता हूं आई एम स्टेटिंग टू एवरी वन ऑफ यू अनलेस यू सी सम 100-200 एक्सरेज ऑफ लंग आपको वो पकड़ नहीं आएगी यू नो बहुत कुछ छूटेगा हाउएवर आई विल शो यू सर्टेन एंड जरूरी नहीं कि आप हमेशा एक्सरे का पेपर हार्ड कॉपी देखो यू हैव थाउजेंड्स ऑफ x-rays pending I mean is there on the Google you can just check it out different conditions में different x-ray टेंशन pneumothorax हुआ तो कैसा होगा pneumothorax हुआ तो कैसा हुआ pleural effusion है तो कैसा हुआ ओके alveolar condition है तो कैसा हुआ ILD है तो कैसा हुआ you know hazardous disease है तो कैसा हुआ all these things you know you have to find out various images because एक ही condition pneumonia can seem different in different x-rays little different थोड़ा तो अलग होगा ही होगा वो everyone's pneumonia is not same but आपके पास concept रहेगा तो you'll be able to find out simple so E से edges of heart as I told you Silaute signs देखना है you have to find out the blood vessels of heart like how it is happening अगर उसमें कुछ changes है तो आपको पता चलेगा इसी में आप angle of Carina भी देख सकते हो which is actually the part of the lung anyway now field and fissures lung and parenchyma field and fissures कहने का मतलब you have to find out the oblique fissures सही है या नहीं horizontal fissures सही है या नहीं राइट लंग में and then you have to find out the field complete black है air है ना so somewhere the suppose in case of TB you'll have a patches okay bronchiectasis अलग होगा हम लोग देखेंगे अभी वो bronchiectasis है तो कैसा तो field पे you have to see lung and parenchyma see मैंने ध्यान से दोनों चीजों को बोला है क्या बोला है lungs को तो बोला ही है everybody check the lung field but do you check the lung parenchyma do you check the lung parenchyma देखेंगे तो कैसा देखेंगे क्या देखेंगे हम उसमें parenchyma क्या कहने का मतलब this is say for example this is alveoli okay अब टाइम आ गया I should tell you so I am telling you this is alveoli say for example alveolus के अंदर जो प्रॉब्लम हो रही है एयर रिलेटेड वो तो alveolar प्रॉब्लम है we agree the problem related to air inside the alveoli is the problem of the air issues उसको बोल सकते हैं alveolar issues लेकिन the tissues which actually support this alveolar tree is the parenchyma. ये तो एयर का प्रॉब्लम है. अभी ये बीच वाला पार्ट जो है parenchyma, मतलब all supporting tissue. Is there any problem in that? It will so different. Parenchymatous tissue may suppose there is an infection. Okay, there is an infection and enematous substance have come out. Any example you can take it. In that case, liquid will appear what? It will appear white, but it is not pure liquid. Then it will appear what? It will appear little white. I mean, it's something that it will not be black like air. Right? So क्या होता है? You have to see whether it's a alveolar problem, whether it's a parenchymal problem. अभी हम उस पे भी आएंगे. ठीक है? So lungs and parenchyma both in pills and pieces we have to see. Now great vessels and gastric bubbles. Vessels आपको बता ही दिया. हार्ट के बॉर्डर्स के बाद vessels आपको देखना है. And then gastric bubbles also you see. If it is a gastric bubbles, PA view में दिखेगा. Hilum, left and right in a single level most of the time. And if it is has to be higher, the left has to be higher. Suppose right has to be right high हो गया तो क्या करेंगे उस केस में? क्या बोलेगा आप? Any one of you can answer. If right hilum is higher than the left, what your suspect could be? Any one of you? You answer even though it's wrong, because unless you go wrong, you cannot go right. Suppose right ऊपर हो गया left से, so what could be the condition? I'm checking. Bhubi, come to the lung only. Will not go to the liver because liver का अलग issue है. Hyperinflation of lung. Okay, I'll come on that later. What is the pulmonary hypotension? Okay, makes sense. Next, anything else? Cancer. Tumor. ओके, छोड़ो वो सब. अभी सीधा आ जाओ बेसिक्स पे यार. ओके, उसके बाद विल गो. सी, देयर इज समथिंग कॉल्ड कोलैप्स. ठीक है? एंड देयर इज समथिंग कॉल्ड कंसोलिडेशन. You know, cardiopulmonary physiotherapy is a subject of my interest. I've taught in college for years. So, and again I'm starting and few batches of e-cardio also classes. So athletics is correct. So, you know, like again, it's going to start. I have no time. So I have not been able to give my time to academy for starting that class. But cardiopulmonary physiotherapy, we have seen in a very detail for about, 10 to 15 classes only devoted to anatomy and physiology related to the conditions. When I took cardiopulmonary physiotherapy, initially in earlier days, it used to be 4 to 5 hours of class. Now later that class went to about 10 hours. Now that class is about 50 hours. So लोग पूछते हैं कि इतने में आप क्या पढ़ाते हैं? तो मैं कहता हूं कि like unless anybody knows about anatomy and physiology properly, and now anatomy and physiology is not something that you need to just see and read all the time. No, we need to correlate with that. So मैंने अभी पूछा आपको collapse and consolidation. अब मुझे बताइए इस दोनों में से एयर का प्रॉब्लम कौन है? collapse और consolidation. एयर इशू कौन है? collapse है या consolidation? collapse है, definitely. It's like a balloon where you pin it and air comes out. So it's a collapse. Now apply the same concept. Apply the same concept in the lung. Okay, you will have X-ray features very easily known. Now let us talk about consolidation. Consolidation में क्या हो जाता है? Elasticity gone for sure. उससे ज़्यादा और क्या हो जाता है? Because of lot of exudate and that the fluid, what happened later, that becomes little tougher. थोड़ा टफ तो हो जाता है. अब आप मुझे बताइए, I'm just talking about schematic diagram, then we will go into our X-ray part later. अब आप यहां देखिए, say for example, this is the lung. Don't judge me with the best of this one. I'm just showing you. Now this is the hilum. ओके अभी हम हाइलम को ये कहना चाह रहा है, राइट हैज गॉन अप, लेफ्ट इज लेस. ओके हाउ इट इज पॉसिबल? इट इज पॉसिबल दैट इफ लोअर लोब इज गॉट कंसोलिडेटेड. निजिन, आर यू अंडरस्टैंडिंग? अगर अगर लोअर लोब कंसोलिडेट हो गया, it will not allow the hilum to go into the natural normal position. So normally it will look higher than the left. Right will look higher than the left. Okay. So आप easily बोल सकता है इस केस में lower lobe consolidation है, because consolidation that means elasticity gone, it's a tough tissue. Am I sounding logical? Logical है. Consolidate हो गया. Consolidate हो गया तो it will not allow the lung to come in a natural normal position. तो आपका हाइलम तो ऊपर ही दिखेगा, राइट? हाइलम विल बी सीन अप. लॉजिकल है? शरद, सौमिक, साहिल, एनीवन? टेल मी. यस. नाउ अपार्ट फ्रॉम दैट, अगर एयर निकल गया, से फॉर एग्जाम्पल it's a collapsed part because of XYZ reason, so what will happen? It will be also showing the feature of abnormal. Very simple. अब हम लोग चलेंगे some of the practice sets, like I'll just check. Yeah, this is the case of cystic fibrosis healthy lung. हाँ, ये मुझे दिखाना था आपको. yes, ये थोड़ा सा देखने वाली चीज है. asbestosis collapse. ये देखो आप, नहीं पहले आप कंसोलिडेशन देखो. हाँ, दिस इज व्हाट आई वाज सेइंग यू. यहां पे हु विल टेल मी व्हाट इज दिस कंडीशन? एनीवन टेल मी? ओके, ये बहुत ही अच्छा है, फेयर एग्जांपल है. आई हैव स्पोकन समथिंग अबाउट कार्डियोपल्मोनरी फिजियोथेरेपी राइट नाउ, द बेसिक पार्ट. नाउ हु विल टेल मी व्हाट इज द कंडीशन इन दिस लंग? चलो बताओ. एडिशनल 5% ऑफ फॉर यू इफ यू आर ज्वाइनिंग फॉर ड्राई नीडलिंग क्लास. लंग कोलैप्स लोअर लो. नहीं बाबा, मैंने ऊपर ही लिख दिया है कंसोलिडेशन, वो तो आपको सोचना नहीं है. ऐसा कंसोलिडेशन ओनली, बट कहां का है? एम्पायमा. चलिए अब थोड़ा सा. हाँ अल्फिया, यू गॉट इट राइट. यस, इट इज मिडिल लोब. वेरी नाइस, वंडरफुल. क्लैप फॉर यू. मिडिल लोब. As a teacher, I could contribute something to you. Very nice. Middle lobe consolidation. Wonderful. क्यों कंसोलिडेशन है आप देख लीजिए, बिकॉज ऑल ऑफ यू मिडिल लोब. थैंक यू प्रियंका. सो इसमें क्या हो रहा है? एक्सुडेट मेनी फ्लूइड विच हैज कम एंड इट हैज मेड द एरिया टफर विच इज नॉट गेटिंग इनटू प्रॉपर एरेशन. सो मिडिल लोब कंसोलिडेशन. थैंक यू सर. सो व्हाट इज हैपनिंग इन दिस केस? इट इज शोइंग कंप्लीट. कहां गए भाई? हाँ, ओके, इट इज शोइंग कंप्लीट. वंडरफुल. सो इट्स अ राइट लोब, राइट लंग मिडिल कंसोलिडेशन. चलो ठीक है, थोड़ा सा ये भी देख लिया. अब दूसरा भी देखेंगे. कोलैप्स. ये है कंडीशन कोलैप्स का. हाउएवर इट इज, आप ये देखो, इज द हार्ट बॉर्डर क्लियरली सीन हियर? क्लियरली सीन है हार्ट बॉर्डर? नो, नो, राइट? तो इस केस में व्हाट डू यू थिंक? ये कोलैप्स है. लेफ्ट लोअर लोब का कोलैप्स है. लेफ्ट लोअर लोब का ये कोलैप्स है. ओके, सो इट इज नॉट क्लियरली सीन. कार्डियोमेगाली, yes. Why? Because left lower lobe is collapse. अब मुझे आप पूछोगे क्वेश्चन, सर कैन यू टेल मी why it is collapse? It like how it is like other things. Other thing आप देखिए यहाँ पे, costophrenic angle is clearly seen. Everybody can see. Domes of the right diaphragm is seen clearly. ठीक है. अब यहाँ पे लेफ्ट डायफ्राम का डोम नहीं दिख रहा है क्लियरली. We are not able to see clearly. नंबर वन। नंबर टू, ये बड़ा व्हाइट हेजी अपीयरेंस है, नो कोस्टोफ्रेनिक एंगल इज ऑल्सो सीन हियर, नहीं दिख रहा है, दैट मीन्स देयर इज अ प्रॉब्लम हियर. So in this case, we can find out the collapse. Pneumothorax. Pneumothorax में भी हम आ रहे हैं. Pneumothorax is different. Pneumothorax अलग चीज है, उसको आप छोड़ दीजिए. But here there is a collapse. Why? Because the diaphragm is not seen. We can see a fusion here. Okay, white दिख रहा है ना? So a fusion. Okay. अब दूसरे सेट पे आते हैं. Healthy lung. It is a healthy lung. Yes, it is a healthy lung. क्यों healthy है? देखो, ये भी दिख रहा है, क्लियरली सीन है, कोस्टोफ्रेनिक एंगल दिख रहा है, ऊपर वाले बॉर्डर भी पूरे दिख रहे हैं, दिस ब्लड वेसल्स आर क्लियरली सीन, बॉर्डर बहुत अच्छे से दिख रहा है हार्ट का, हाइलम भी प्रॉपर दिख रहा है, एवरीथिंग इज प्रॉपर. बट यहां जैसे ही हम आते हैं, बॉर्डर की इश्यू तो नहीं है ज्यादा, प्रॉब्लम क्या आता है, इसका आता है, डायफ्राम के डोम का. एंड यू नो वेरी वेल इन आस्थमा, एंड सी interestingly the costophrenic angle is seen, right? तो इसमें क्या हो रहा है, बेसिकली इन आस्थमा व्हाट इज हैपनिंग, हाइपर एक्सपेंशन ऑफ लंग. वंडरफुल, वंडरफुल. आई डिड नॉट सी योर नेम, निजिना. वंडरफुल. इट्स अ हाइपर इन्फ्लेशन ऑफ लंग. आप देख सकते हो द लंग हैज अ, इतना हाइपर इन्फ्लेट हो चुका है, इट इज एक्चुअली नॉट लेटिंग द डायफ्राम टू कम प्रॉपर. ओके, तो डोम दिख ही नहीं रहा. ओके, सो दिस इज हाउ यू हैव टू हैव अ कॉन्ट्रास्ट. वो 10 चेकलिस्ट को दिमाग में रखिए, राइट फ्रॉम ए फॉर एयर से लेके आई फॉर इंस्ट्रूमेंट तक सब देख लीजिए. यू कैन एक्चुअली विन द एक्सरे गेम इजिली. आप हाथ में उठाया एंड यू कुड रीड इट वेल. वेरी नाइस. अभी एक ब्रोंकिक्टेसिस का केस हम देख लेंगे. वेल, ब्रोंकिक्टेसिस के केस में व्हाट इज द मेन इश्यू, व्हाट इज द मेन इश्यू ब्रोंकिक्टेसिस के केस में, लाइक वेयर इज द पैथोलॉजी इन दिस ब्रोंकिक्टेसिस में? Is the pathology directly for alveoli or it's the pathology of bronchioles? I'll wait for your answer. Kinking, bronchioles, yes, collapse of bronchioles. Wonderful, wonderful. So आप उसमें देख सकते हो, आपको लंग फील्ड में एल्वियोली के लेवल पे तो कुछ दिख ही नहीं रहा, इट्स एयर. बट यहां पर देख लो, ब्रोंकिक्टेसिस. ऐसे केसेस में ब्रोंकिक्टेसिस, हार्ट के बॉर्डर भी क्लियरली सीन नहीं है, यह हालत कर दिया है. इट्स अ क्रॉनिक केस ऑफ ब्रोंकिक्टेसिस, यू कैन सी. जबकि इनका कोस्टोफ्रेनिक एंगल कंप्लीटली सीन है, सो देयर इज नो केस ऑफ प्लेउरल एफ्यूजन, है ना. डोम्स ऑफ डायफ्राम इज लार्जली नॉर्मल, नॉट बैड. ठीक है, इसी तरह हमको चेक करना है. अभी सिस्टिक फाइब्रोसिस देखेंगे. अच्छा ठीक है, सिस्टिक फाइब्रोसिस में आने से पहले we will go something. Asbestosis, ये मैं बोलना चाह रहा था. You know, there, have you heard of ILD, interstitial lung disease? इंटरस्टिशियल लंग डिजीज, है ना. इस केस में क्या होता है, as I told you, more than alveoli, what is involved? It is the involvement of interstitium of the lung, parenchyma of the lung, which is actually the supporting tissue for the lung, right? ऐसे केसेस में क्या होगा, थोड़ा ध्यान से देखिए. You will have a, मैं इसको ना थोड़ा बड़ा करना चाह रहा था, I don't know whether it will be, anyway it will not get big now. आप देखोगे तो देयर विल बी अ रेटिकुलर फॉर्मेशन, रेटिकुलर व्हाइट फॉर्मेशन एवरीवेयर इन द लंग फील्ड. आप देख रहे हो ना, स्पेशली इन द मिडिल एंड लोअर लोब, है ना. दिस इज द टिपिकल कैरेक्टरिस्टिक फीचर ऑफ एनी सॉर्ट ऑफ इंटरस्टिशियल लंग डिजीज. स्कैरिंग, करेक्ट, स्कारिंग, टिपिकल इंटरस्टिशियल लंग डिजीज का ये फीचर आपको ना, रेटिकुलर फॉर्मेशंस, धागे जैसी आपको हर जगह मिलेगा लंग्स में. मतलब it depends upon the obviously the severity of disease, but yeah, I mean, yes, asbestosis is one of the, just 1 minute, just 1 minute. बाद में asbestosis, as I told you, it's a diffuse scattered. So what happened? Reticular formation. तो ये आपको ILD को सोचना ऐसे है. That is how you differentiate between the interstitial lung disease and the alveolar type of disorder. What that time Nijin was saying is a hyperinflation of lung. Yes, it's a hyperinflation of lung. So you can find out it's a COPD kind of condition, especially the bronchiectasis. But in this case, what is happening? Lung condition is normal. Lung could be largely normal in size. Okay, but problem kahan aati hai? Formation. Okay, this is how you have to select. Now somebody is asking me, why didn't I bring the COVID X-ray? Let me tell you, COVID X-ray or normal this में COVID में X-ray में you cannot see most, like lot of things you cannot see. Anyway, अभी COVID पे नहीं बहुत बात करनी है, बहुत हो गई बात. Now cystic fibrosis, same. I don't know whether I have got that for you or not. Yes, yes. So what do you see in cystic fibrosis? The best part is cystic fibrosis में the best part is you are able to see what is the again reticular formation, but इसमें क्या होता है, थोड़ा bronchiectasis features भी मिलेंगे आपको. Okay, so it is a thick walled bronchiectasis type of structure. Okay, this is how as you know, this disease is a kind of fibrotic and then always retracted. So in intervening, it's a like a entire lung is affected. That is also one of the feature of cystic fibrosis. And then if you talk about like other features, like in case of cystic fibrosis, hyperinflation can happen or not. Yes, it can happen because it involves the bronchiectasis as well. And then you have the process of, you have the some regions of consolidation as well. So that is how the cystic fibrosis definitely differs. So I just wanted to attach, and you can see that there is no heart border seen properly, and you can see the patches, not patches, more of reticular structures, thick walled, scarring kind of structures more of, and then many a times it is a pneumothorax as well. Okay, and यहाँ पे भी आप देखिए, like you cannot see, yes, saggy heart borders, yes, definitely. And then you can see here costophrenic angle is not seen. कहाँ गया भाई? Costophrenic angle is not seen properly. देख लीजिए आप, healthy lung से you can compare and see. नहीं दिख रहा है ना? DOMS largely okay, not bad, but here you can see costophrenic angle. So many times in advanced condition, what is happening? The pulmonary artery का भी hypertension देखा गया है. तो आपको जब यहाँ देखेंगे, आप artery का features जब देखेंगे, तो यहाँ पे आपको दिखेगा, it's highly compressed, so saggy, complete saggy. You can see aorta is normal, blood vessels are hilum, blood vessels are like largely disturbed. So this is one of the X-ray. You can find out some 5-6 X-ray, you'll learn it, not a problem. One more I wanted to show you, I'm not able to get it. Pneumothorax is okay, you can see. I'll find out in my list whether I got it that or not. I don't know, I have got pleural effusion, I'll just find out. Pneumothorax की case में what do you say? So lung marking, lung के जितने भी markings हैं उनका दिखना कम हो जाएगा. Okay, some there is a sign, you know very well. What do you say that sign? Deep sulcus. I think I'm correct. Yeah, deep sulcus sign आता है in this. इनका ये जो होता है ना, मतलब इनका जो कोस्टोफ्रेनिक एंगल होता है ना, एबनॉर्मली शार्प होता है. ओके, इट्स नॉट नॉर्मली शार्प, इट्स एबनॉर्मली शार्प. देखते ही लग जाएगा. इट इज वन ऑफ द लाइक फीचर्स ऑफ कोस्टोफ्रेनिक एंगल, स्पेशली जब उसका एपी व्यू लेते हैं सुपाइन. सो मोस्ट ऑफ द केसेस न्यूमोथोरैक्स में आप देखोगे एबनॉर्मली शार्प कोस्टोफ्रेनिक एंगल. एंड देन ऑफ कोर्स वन ऑफ द मोस्ट इंपॉर्टेंट फीचर इज व्हाट? डायफ्राम फ्लैटनिंग. डायफ्राम उनके फ्लैट होते हैं, फ्लैटनिंग. ओके, एंड अदर फीचर्स, एनीवन टेल मी? ट्रेकियल डेविएशन है ना, ट्रेकियल डेविएशन, you should be telling me this. Okay, signs of tension pneumothorax also is seen. ठीक है, signs of tension pneumothorax and mediastinal shift from the pneumothorax. All these things are the common features of pneumothorax. You can just see the X-ray and can find out. Again, I would tell you to find out more X-rays and see. Consolidation, हाँ, pleural disorder मिला है, एक तो रखा है मैंने. Pleural disorder. Can you tell me what is abnormal in this? I leave upon you. I'll wait for your answer. After this, we are done for the day. So, like pleural effusion का एक है, sorry, मैं ही बोल दिया. Pleural disorder का एक X-ray है. What do you see abnormal into this? Pleural effusion, wonderful. Effusion, very nice. Anything else you can see? Because this is the last phase, last exercise, we are exercising. Left lower lobe effusion. इसको थोड़ा और अच्छे से बोलिए वनिष्ठ का. लेफ्ट लोअर लोब वाला पार्ट जो आपने बोला है, एफ्यूजन तक ठीक है, बट अपार्ट फ्रॉम दैट व्हाट यू कैन से? कोलैप्स, राइट? कंसोलिडेट होता तो इट कुड हैव प्रेस्ड. इट्स अ okay, anyway, leave that. Yeah, what is the dark spot on the left diaphragm? No, I am asking you a question. First you answer, then we'll discuss. Lower lobe has excess fluid accumulation, left lower lobe collapse. Next. Peritoneal effusion. White field is pleural effusion. Lower lobe, correct. Left lower lobe abscess, that's also correct. Okay, that's good. Anything else? Anything else? Let me know. Till then, I'm checking if I can get some more images for you. What all things you can? I'm actually waiting. Flat, come on, right? Okay, that's okay. Anything else? Lower lobes count not possible. No heart border. Wonderful. I'm actually waiting to add up some more images. Nothing else. I don't know. I'm not able to get it. Blending of costopharyngeal angle, correct, 100% correct. Look, all of you spoke everything being connected to this. And I will tell that that's a correct also. But none of you actually observed this. This is literally abnormally thick white, isn't it? Abnormally thick white. So last case is abnormally thick. What do you think about it? You got my point, what I'm saying you. Abnormally thick. So ye kya hai? This is a pleural effusion. Left clavicle? No, Baba, I'm not saying that. You can see here, this particular area. ये पूरा देख रहा है ना आप? ये पूरा देख रहा है ना आप? this completely area, this abnormally more white. So what is that? That is a pleural effusion. Now this is different thing. There are three types of effusion, lamellated, located, and sub. Tell me, sub. सब पल्मोनिक. ओके, सब पल्मोनिक ही ज्यादा कॉमन है. उसमें हम देखते हैं कि वो लाइक देयर आर लॉट ऑफ थिंग्स टू सी, लाइक गैस्ट्रिक बबल से कितना दूर है, 7 mm दूर, 7 cm दूर है या सेंटीमीटर. There are some methods. I actually am not into that much GI radiology, but yeah, access of pleural space. Okay, ओके, एक्सेस ऑफ प्लूरल स्पेस. या सो क्या लग रहा है आपको, व्हाइट जो है वो क्या है, वो फ्लूइड तो है. सो यू शुड टेल यस सर, इट इज अ प्लूरल एफ्यूजन विथ अगेन ऑफ कोर्स द लेफ्ट लोब का जो भी है, यू हैव टोल्ड, दैट्स ओके. ओके, सो इट्स अ केस ऑफ प्लूरल एफ्यूजन. सो प्लूरा को भी नजर रखना है. यू कैन नॉट लीव द प्लूरा ऑफ द चेकलिस्ट में. एक पार्ट प्लूरा का भी आता है along with the lungs and parenchyma, right? So आपको हमेशा ध्यान रखना है प्लूरा में कि प्लूरा के बारे में क्या जानना है. सो प्लूरा में हमेशा आपको ये चीज नजर में रखना है. यू कैन नॉट लीव प्लूरा आउट. सो प्लूरा इज समथिंग वेरी वेरी इंपॉर्टेंट. सो प्लूरल एफ्यूजन. अभी just 1 minute, I'm trying to add up I'm trying to add up one more image. I'm not able to get it where I've kept. Just 1 minute. I'll be back with this share. Just 1 minute. I'm actually trying to get an image for you, which is important. Didn't I find that image much today? We did not find it. Pneumothorax. Just 1 minute. I'm just, I have got that image. I'm getting it for you. Then after that, we'll be finishing for the day. I'll come on everyone's question. Don't worry. Somebody was asking me that, I still remember you were asking me about cystic fibrosis or वो, right? तो आपको पता ही होगा सिस्टिक फाइब्रोसिस जो है वो जेनेटिक डिसऑर्डर है. So pulmonary fibrosis से you have to differentiate in that way. ILD जो है वो एक्वायर्ड होते हैं, ओके, बट सिस्टिक फाइब्रोसिस जो है वो जेनेटिक डिसऑर्डर है. So that you have to keep in the mind. This is how you differentiate. I have got it. So still not very clear. Just one more time. Yes, I've got it. 1 minute. I'm sharing it. I wanted to let you know about it, so it's important actually. I wanted you to know about tension pneumothorax, nothing else. Because I think it's coming to everyone's screen now. Yeah, see, this I wanted to bring for you, tension pneumothorax. I missed this image somewhere else. Okay, so it took about 2-3 minutes to bring it. So what do you know about tension pneumothorax? Can anyone tell me in a very brief what is tension pneumothorax? You understand? Anyone? Briefly in chat. What is pneumothorax? Same thing, but you have to add up something different. Needle induced, huh? I know that's the reason. One of the area, like one of the mechanism, you have to just explain what is error collapse between the parietal and visceral pleura, resulting in lung collapse. Okay, okay. Mediastinal shift accompanied air trapping in pleural space. That's good. So it's a severe condition, basically, right? Where the pleural space, where the positive pressure, actually should be negative. So it's a positive pressure which actually presses what? So it will press what? How much time is required for the session? Okay. Your base, ma'am. Yeah, another 5 minutes. So pleural space positive pressure, correct, Swami? So to one side of airy positive to negative pressure, right? So what it will cause? How do you, sorry, I did not see your message. What do you say? Midline shift opposite side. That's what I wanted to see this message from anybody. Wonderful. Wonderful. So it's a midline shift basically. So booby, I think, yeah. So it's a midline shift to one side. That's good. So yeah, traumatic chest injury, completely correct. So what happened? We have to find out the mediastinal pressing toward one side. Okay, so this is not very clear image. Yeah, fine, I got it somehow. So you'll always find the mediastinal getting shift toward one side. And then what happened here? Most of the time, what is happening? Just 1 minute. Hello. Okay. So what happened basically here? If you see a schematic diagram, easily you can see like a lung is there, and then like air comes in pleura, makes it more what you say, in case of inspiration, that becomes more and more, and the pressure starts creating here, and then other side becomes the shorter. Okay, other side becomes the shorter. So in expiration case, again that continues. Okay, so this is how the tension pneumothorax is always problematic. This is different thing that we have a 3 types of like a pneumothorax. In that, pneumothorax is one type, is the what? Tension pneumothorax. So pleural cavity pressure is, as you said rightly, is more than the atmospheric pressure, and this is how it actually starts shifting the mediastinum to one side. So this will be clearly seen in one X-ray. Why did I wait for 2 minutes and got this image for you? Because tension pneumothorax I did not want to leave. However, another type of pneumothorax I have already shown you. Like I think it was a closed pneumothorax, where the pleural cavity pressure is less than the atmospheric pressure. That's all. And then there is one more. I think anyone can tell, open pneumothorax, where both will be equal, like pleural pressure as well as the pleural cavity pressure as well as the atmospheric pressure. This will be equal. So that we say as a open, when the pressure remains equal. But when in closed, which is very common condition actually, pneumothorax closed wala, उस केस में क्या होता है? Air in pleural space cavity का जो pressure है, pleural cavity IPP जो भी है, that will be equal to the atmospheric pressure. Okay, and then there is a tension pneumothorax. इसमें क्या होगा कि इसमें atmospheric pressure remains less than the pleural pressure because it is a sudden entry of the air. Okay, so आप देख सकता है, it's a sudden entry of air. So, this is not very clear image, but still I got for you. Just, I didn't want to leave. I didn't want to miss this particular point. However, we have more than 50 type of, like a X-ray to be seen when it comes to pneumothorax. When it comes to the total lung X-rays, there are a lot of things. So this is how we see this particular thing. And then एक्सरे का बेसिकली आप चेस्ट के लिए वही 10 चेकलिस्ट याद रखिए, वही काफी है आपको. मोस्ट ऑफ द टाइम इट विल हेल्प यू. नाउ इज देयर I have a question to you. Now, suppose somebody has a consultation, हमने डिस्कस कर लिया, right? I think right middle low consultation we discussed here. So suppose pleural भी डिस्कस कर लिया. Yeah. So अभी आपको एक क्वेश्चन मैं देता हूँ before you ask me anything. Somebody asked me about cystic fibrosis and ILD. See, ILD का केस में क्या होता है? ILD could be acquired, as I told you. Even the asbestosis or pulmonary fibrosis and all those things are acquired. But when it comes to cystic fibrosis, that is a genetic disorder. Okay, so वो ध्यान में आप रखिए. Don't come. So what happened here? Don't come. So what happened here in this case? If I ask you one question, there is a person who has a RTA, road traffic accident, and there is a multiple injury. Okay, there is a multiple injury including thorax. Okay, pneumothorax भी होएगा ही होगा, करेक्ट है. आपके पास एक्सरे आता है, तो what would you prefer to see? PA or AP? I want to know from your answer. I should have asked AP or PA or both. I did not ask the third option. Actually, we need to see both. As you said, very standard X-ray view is what? PA. Okay, PA is for air, as you said rightly. AP is basically for the bones को देखना है तो AP is the best. आप देख सकते हैं, ठीक है. अभी now I have another AP for bone penetration. Very nice. Now I have another question. Suppose a person has fallen and he is actually working as a carpenter. He has fallen and there are a lot of metal pieces has gone inside his feet. So you have taken X-ray. What do you differentiate in that X-ray from the bone? What are you going to see? He has injury as well. He has fallen into that particular toolbox or something, but he has very bad injury. So what do you see? What do you do? Very white particles. Very nice. Very nice. Very nice. Very white. Very white. So you can actually find out now, is there any amount of bones? Suppose bones also is there. There are many parts of bone. Just 1 minute. I'll put a. So there are many parts of bone. Okay. Pieces of bone also you can find out, and along with the pieces of small tools, everything went. Why? Because the bone will appear less white than the metal pieces. Got it. You got your point. Very nice. Very nice. Anyone, any question is there? You can ask me. I'll listen to your question and wait to answer. Otherwise, I'll give that code. You can the code you can just send to the number and you'll get a form. You can fill your complete name. The certificate will be there in your inbox in some time, maybe in a minute, or if it comes, it takes sometimes up to 72 hours, but it will go to your spam box also sometimes. So please check your spam box also. So is there any question you can ask me? I know these things are not to be covered so fast, but still I tried my best to cover the spine and lung. Achha, you asked me earlier also, I think, what is the dark spot over the left diaphragm? I also did not see. Maybe that air bubble you are able to see. Explain carcinogenesis versus spondylolisthesis. X-ray point. Carcinogenesis. What is carcinogenesis? Spondylolisthesis alag hai. Carcinogenesis, I didn't get you. Like, what do you, can you be a little more clear about it? Retrolisthesis. Okay, spondylolisthesis and retrolisthesis. What is mean by retro? Problem solved. Problem solved ho gaya. Okay, so just go to the basics. Problems are solved. Don't worry about it. So collapse, what is the appearance? That's what I'm saying, yo. Collapse ho jayega, so there is nothing to be seen, right? क्योंकि air तो निकल गया, तो space will be less. Consolidation हो जाएगा, so space will be there, but that consolidated part will be little whiter. Okay, it won't be black because there is not air. There's some fluid in that, right? Some infection is there. ओके समझ रेट्रोलिस्थेसिस आप पोजीशन देख के पता कर सकते हैं मैडम, नो प्रॉब्लम. ठीक है, आप समझ गए. कंसोलिडेशन होगा तो कुछ ना कुछ लिक्विड होगा ही वहां पे, कुछ ना कुछ फ्लूइड तो होना ही होना है. अगर नहीं भी होगा तो दैट विल बी, स्पेस विल बी लिमिटेड बिकॉज इलास्टिसिटी इज लॉस्ट. तो आपको ये ध्यान देना है, कोलैप्स में स्पेस विल बी लेस, कंसोलिडेशन में स्पेस विल बी मेंटेन्ड, बट अपीयरेंस विल बी डिफरेंट. करेक्ट है? आई डोंट नो हु आस्क्ड दिस क्वेश्चन, बट आई एम श्योर दैट गॉट इट. अनामिका, यस, डिड यू गेट इट अनामिका? कोलैप्स में आपका स्पेस ही खत्म हो गया ना, एयर हैज गॉन आउट. या अंडरस्टूड, वेरी नाइस. Consolidation में space will be limited. Yeah. Pulmonary embolism is a condition where the blood clot cannot be seen on X-ray. How to find out? Okay. Yeah. Any other question you have? Keep asking. Then I'll give you the code. I'm searching the code. I think it has come to my mail ID. COPD, what can be the X-ray interpretation? See, COPD is not a condition, it's a very big condition. So if it is a hyperinflation, you can see the abnormally, that time you were saying, no, like a more lung space, more blackish, and other things like you have to see the hilum structure, you have to see everything. Pneumothorax X-ray, lung collapse difference. Just now we discussed, ma'am, pneumothorax and lung collapse. Just now I was discussing. Just find out in my YouTube video again what I have told. So collapse ke case mein air has gone out, the space will be less, but pneumothorax mein still that is intact. Okay, so in that case you'll find a proper like air will be there, but you'll find in a different way. That's all. Lung filled, if you see, you'll be able to see properly. Thank you, Fija. I'm checking out in certain questions if I have mediastinal shift in IT and collapse. Okay. Yes, definitely yes. Pneumothorax hoga to zyada air hoga to hoga. One question somebody asked me regarding electrolysis. I think I answered that you have to see the position. Sahit, nah. Pulmonary embolism. You were asking. Okay. Okay, fine. See, if you go through the book, I mean, obviously, I mean, even in my like complete class, in that condition wise, I have given certain specific point. If you talk about pulmonary embolism, it is largely, I can tell you the normal. If you take the radiograph of pulmonary embolism, it's largely normal. But in some cases, which is like advanced cases or something, in that case, you know, pulmonary vessels, I'll come to that particular image then only. Okay. Just 1 minute. Yeah. In this also we can see. Yeah. Pulmonary vessels को देखिए साहिद, क्या होता है ना, pulmonary vessels will be dilated. ये जो है ना, ये सारे pulmonary vessels जब आप देखोगे इन proper X-ray film, radiograph, ये dilate होते हैं. Okay, in advanced stages. So most of the time, you will find the very clear dilation. Okay, I forgot the particular. There is a sign. Watermark sign or Westermark sign, something is, there is a sign. Okay, in another class I have discussed that particular sign. You will be able to see in the later stages. Obviously normal stages, so you will not be able to find out. And then obviously you will have atelectasis. You will have a very low degree, but you will have a very low degree of elevated diaphragm also, because embolism hai, elevated diaphragm. And then you may have some you may see some of the like a pleural effusion as well. That is possible. Yes, but as you rightly said, initial cases you cannot. Yes. Yeah, thank you so much everyone. So I'm going to give you the code. I hope I have cleared the most of the things. Some more informative session. Thank you, Ridhi. Western mark sign. Thank you, Sai. So watermark sign, Western mark sign, something I was forgetting. Yeah, thank you. That's all for the day. Thanks for your presentation. Don't forget to give your valuable feedback. I'm thanking every one of you who joined today. I have got in my mail. I am integrating with your group so that you can get it. What is that? 2 minutes. I will not see the chat. I'm actually seeing your 2 minutes. I will not see the chat. Don't worry. 2 minutes. I will actually, I'm trying to bring that code on the platform. Give me a time. Give me 1 minute, because code is something which is very, very important. You have been sitting here and learning a lot. Yes. Just 1 minute. Yes, code has come. I'm actually displaying over screen. I think somebody asked me some. It's really informative. Thank you, Sai. Thank you. It was really informative. Thank you, Sabina. Thank you for available time. Thank you so much. I'm sharing your code. So what you have to do, you have to send this code through WhatsApp to 9066990059. One sec, I'll share it. Yeah. I hope everyone is able to see. Yeah. So this is the code XR1, no space, no small letters, and kindly send this code to 9066990059. You want me to type in chat as well? So those who are getting certificate, kindly inform here also. Yes, you are getting it. So you'll get a link. In that link, if you fill up your name, it will come. Okay. Sahid, you were asking some question I did not see in your chat. Now I'm seeing that. How does it appear? Obviously, it will appear what? It will appear. It will appear. If Sahid is there, can hear me. It will appear little more lucent, hyperlucent. That's all. Okay, it will be a sign hyperlucent. Vessels are collapsed means most of the time it will be hyperlucent only. So everybody is able to see. I hope it's coming to everyone. Anyone asking me later code, I cannot help you. I'm making it very clear. Now only whoever is able to see, please get this and finish your certificate part. Nizin, did you get your certificate? You can unmute yourself. You can unmute yourself.
Yes,
You can't? Okay, sorry. Okay, no problem. You just send this code to 9066990059 through WhatsApp. You'll get a link. In that link, you put your complete name. Nicely, you put your name, and then the certificate will be with you within few minutes. Somebody is asking like next Sunday you haven't got any link. No, not like that. The link for next Sunday will come only on Sunday morning, not before that. Okay, and next Sunday we are having a GATE discussion, GAIT GATE training, and it's by a wonderful person. He is our regular senior scientific coordinator, and sir is very famous, very popular. He's a PhD guide. Also, he has guided many more person in for PhD research. Dr. Arunachalam Ramachandran, he is coming for taking GATE rehab. So those who all are our members and students, please join us by 9:30 to learn something which is very different topic, and then very important topic. In fact, more than different, it's a usable topic. And XR1, WhatsApp this code to 9066990059. So those, anybody, no link showing? Got, sir, thank you. Sutapa has got it. Aman Kumar saying no link. Link will come to you. Don't send very frequently. More than that, got, sir. Fija also got. Thank you. Thank you so much. Thank you, Rajesh. All will get a link also for valuable feedback. So please, Dr. N. Vijay Ramakrishna got it. Thank you so much. So, kindly put valuable feedback, if you put up valuable feedback like how was the study and how did you get it and what you learned, we'll be able to bring you a lot of courses for you. Somik also got it. Sahid also got, I think. Okay, he's writing anyway. So anyone of can't get Riddhi Thakur, do one thing. Do send this text XR1, this particular code to 9066990059 through WhatsApp and send only once. You'll get a link. If not now, after 3-4 hours, but you'll get a link. Got my certificate. Vasika, thank you. Thank for your participation. Vansika, sorry. So that's all for the day. I believe that another 2 minutes for your certificate. Can I ask Riddhi Thakur, what do you want to ask Riddhi? Thank you once again. Thank you, Sahil. Got my certificate. Thank you, Shraddha. Thank you, Sahil. Just fill up that link and wait for the certificate. It will come within a minute. Got my certificate. Thank you, Akshada. Thank you. I personally see every message. Got it. Thanks. Thank you, Sabir. Okay. Thanks for your wonderful participation. Another 1 minute for this code, which will be displayed. I receive message. Thank you, Alfia. Thank you. Thank you. Those who have got certificate can leave. You'll get the link for feedback later today for your valuable feedback and what course you want us to bring. The link shows some sign in option. Okay. Haven't you signed in earlier? Through your Gmail? You can just sign in with the same Gmail. It will happen. Riddhi? And my audio has been disconnected. That will be okay. Do one thing, Riddhi. You just send the link once and wait for 3-4 hours. You can talk to the academy or my number also, 9008533336. I'll see if there is any problem with, or you can check in your spam box also later. It will come to you. Thank you everyone for joining. It was wonderful. Riddhi Thakur, you are okay. I mean, you can actually speak to me later. No problem. Anamika, yeah, yes. Good. Thank you, Anamika. Thank you, Sahil. Thank you, Apeksha. So we are done for the day. Thank you, Aman. Thank you, Aman. I would like to next session again with you, sir. It was very interesting. Thank you, Fija. No problem. Whenever it comes, it will be notified to you. You're always welcome to join. Got certificate. Those who all are willing to join the dry knitting in Bombay can personally message me. Your additional discounts cannot go through online booking. I have to make it offline. Yeah, Dr. Riddhi Thakur, is there any update with your link? If you are not able to get, you can always contact me later. No problem. I'll see. Is there any problem? I think if you are logging in through your Gmail, it will definitely happen. Thank you, Vansika. Thank you, Nijin. Thank you, Priyanka. So I'm actually now removing the code which is displayed. And you all can join Econ also. There's wonderful things to learn from various persons from across the globe. And thank you everyone for your participation. The dry knitting in Bombay. IUC, this is on August 2nd to August 6th. Are you from Bombay? Or you can join in Bombay, because this time it is in Bombay only. Okay, well, it is there from August 2nd to August 6th. So you can take down my personal number and can call me or message currently in Bangalore. Okay, well, it's in August 2nd to August 6th. This is the 5 days in Bombay. You can always contact. I will give you the my like additional discount will be on for you guys. Thank you. Thank you, Said. Thank you so much. Thank you, CEO sir, and everyone for your wonderful participation. We'll meet up sometime later with new courses.